161. Dermoid cyst, this is about 4x less common than an epidermoid. It's more common in kids and young adults. Usually midline, and usually are found in the third decade. They contain lipoid material, and are usually hypodense on CT, and very bright on TL. They are associated with NF2. Trivia. These are usually midline. Most common location for a dermoid cyst is the suprasellar cistern posterior fossa is number 2. This vs that, dermoid vs epidermoid. The easy way to think of this is that the epidermoid behaves like CSF, and the dermoid behaves like fat. IAC lipoma, it can occur, and is basically the only reason you get a T1 when you are working up CPA masses. It will fat SAT out because it's a lipoma. There is an association with sensorineural hearing loss, as the vestibulocochlear nerve often courses through it. Arachnoid cyst, common benign lesion that is located within the subarachnoid space and contains CSF. They are increased in frequency in mucopolysaccharidosis, as are peривascular spaces. They are dark on flare, like CSF, and will not restrict with diffusion. How can you tell an epidermoid from an arachnoid cyst? The epidermoid restricts, the arachnoid cyst does not. 162. L. Infratentorial, most are PEDs, hemangioblastoma is the exception. Atypical teratoma I rhabdoid, these are highly malignant tumors, HUTV, and rarely occur in patients older than 6 years. The average age is actually 2 years, but they certainly occur in the first year of life. They can occur in supra- and infratentorial locations, most common in the cerebellum. These are usually large, pissed-off-looking tumors with necrosis and heterogeneous enhancement. Juvenile pilocytic astrocytoma, JPA, just think cyst with a nodule in a kid. They are WHO grade 1, but the nodule will still enhance. This will be located in the posterior fossa, or optic chiasm. Pihasit C astroctoma, cyst and nodule in kid. Diffuse brain stem glioma, DPG, seen in kids age 3 to 10. Most common location is the pons, which is usually a high-grade fibrillary glioma. It's going to be T2 bright with subtle or no enhancement. The fourth ventricle will be flattened. The it-paging features are so classic that no biopsy is needed. Ganglioglioma, this guy can occur at any age, anywhere, and look like anything, and was discussed under the cortical lesions, page 155. Medulloblastoma, discussed with the 4 lesions, page 157. Ependymoma, discussed with the JV lesions, page 156. Hemangioblastoma, first things first, immediately think about this when you see a cyst with a nodule in an adult. Then think von Hipp, Lindau, especially if they are multiple. These things are slow-growing, indolent vascular tumors that can cause hydrocephalus from mass effect. About 90% of the time they are found in the cerebellum. There is an association with polycythemia. I say posterior fossa cyst with a nodule, PEDS, you say PA. I say posterior fossa cyst with a nodule, adult, you say hemangioblastoma. 163. Supratentorial, most are adults, DIG, DNET, PXA are exceptions. METS, the most common supratentorial mass, discussed on page 160. Astrocytoma, most common primary brain tumor in adults. Tumors fitting in the category include pilocytic astrocytoma, WOL, diffuse astrocytoma, HU2, anaplastic astrocytoma, HU3, and GBM, HU4. Remember that low-grade tumors don't typically enhance, WH02, and higher grades do, GBM, and some anaplastics. The exception to this rule is the pilocytic astrocytoma, which often has an enhancing nodule. GBM is the beast that cannot be stopped. It grows rapidly, it can necrose, it crosses the midline, and it can restrict on diffusion. Remember Tickett syndrome, that GI polyp thing, is associated with GBMs. Gliomatoses cerebri, a diffuse glioma with extensive infiltration. It involves at least 3 lobes and is often bilateral. The finding is usually mild blurring of the gray-white differentiation on CT, with extensive T2 hyperintensity and little mass effect on MR. It's low grade, so it doesn't typically enhance. Oligodendroglioma, discussed under the cortical tumors, page 155. Primary CNS lymphoma, seen in end-stage AIDS patients and those post-transplant. EB virus plays a role. Most common type is non-Hodgkin B cell. Classic picture would be an intensely enhancing homogeneous solid mass in the periventricular region, with restricted diffusion. However, it can literally look like and do anything. Classic multiple choice test question is that it is thallium positive on SPECT, toxo is not. I say restricting brain tumor, you say lymphoma. These next 3 are most common in PEDs. PXA, pleomorphic xanthostrocytoma discussed under the cortical tumors, page 48. DNET, discussed under the cortical tumors, page 155. Desmoplastic infantile ganglioglioma, I astrocytoma, DIG, these guys are large cystic tumors that like to involve the superficial cerebral cortex and leptomeninges. Unlike the atypical teratoma I rhabdoid, these have an okay prognosis. They always arise in the supratentorial location, usually involving more than one lobe, frontal and parietal most commonly, and usually present before the first birthday. Buzzword is rapidly increasing head circumference. 164. L. Skull base. Base. Spordoma, THJS, is a locally aggressive tumor that originates from the notochord. WTF is the notochord. It's an embryology thing that's related to spine development. The thing you need to know is that the notochord is a midline structure. Therefore all chordomas are midline, either in the clivus, vertebral bodies, especially C2, or sacrum. You cannot get them in the hips, ribs, legs, arms, or any other structure that is not totally midline along the axis of the axial skeleton. Things to know: it is most common in the sacrum. Number 2 is the clivus. When it involves the spine, it's most common at C2, but typically extends across a disc space to involve the adjacent vertebral body. It's T2 bright, it's always midline. Chondrosarcoma, this is the main differential of the chordoma in the clivus. The thing to know is that it is nearly always lateral to midline. Chordoma is midline. These are also T2 bright, but will have the classic arcs and rings matrix on a chondrosarcoma. Obviously you'll need a CT to describe that matrix. Dura. Meningioma, as described above, it is common and enhances homogeneously. The most common location is over the cerebral convexity, and it has been known to cause hyperestosis. Hemangiochryscytoma, this is a soft tissue sarcoma that can mimic an aggressive meningioma because they both enhance homogeneously. They also can mimic a dural tail, with a narrow base of dural attachment. They won't calcify or cause hyperestosis but will invade the skull. Mets, the most common met to the dura is from breast cancer. 80% will be at the gray-white junction. They will have more edema than a primary tumor of similar size. 165. Sella I paracella, adults. Pituitary adenoma, the most common tumor of the sella. They are seen 97% of the time in adults. If they are greater than LCM, they are macroadenomas. When functional, most are prolactin secreting, especially in women. Symptoms are easy to pick up in women: menstrual irregularity, galactorrhea. Men tend to present later because their symptoms are more vague, decreased libido. On MR, 80% are TL dark and T2 bright. They take up contrast more slowly than normal brain parenchyma. Things to know about pituitary adenoma. Microadenoma under 1 ohm. Macroadenoma over 1 ohm. Microadenomas typically form in the adenohypophysis, front 213. Prolactinoma is the most common functional type. Typically they enhance less than normal pituitary. Pituitary apoplexy, hemorrhage or infarction of the pituitary, usually into an enlarged gland, either from pregnancy or a macroadenoma. Here are the multiple choice trivia: association, taking bromocriptine, or other prolactin drugs, Sheehan syndrome, in pregnant woman, cerebral angiography. They will be TL bright. Remember, adenoma is usually TL dark. Supposedly this is an emergent finding because the lack of hormones can cause hypotension. Raft cleft cyst, usually an incidental finding that is rarely symptomatic. They are variable on TI and T2, but are usually very bright on T2. They do not enhance. Epidermoid, discussed on page 16J. Remember, these guys restrict on diffusion. I say midline supracellular mass that restricts diffusion, you say epidermoid. Pituitary apoplexy. Shown on TL bright pituitary. Craniopharyngioma, they come in 2 flavors, A. papillary and B. adamantinotomous. The papillary type is the adult type, pappy for pappy. They are solid and do not have calcifications. They recur less frequently than the adamantinornatus form because they are encapsulated. They strongly enhance. The relationship to the optic chiasm is key for surgery. Pediatric type is discussed below, under on the next page with the PEDS tumors. Tumors. 166. L. Sella I paracella, PEDS. Craniopharyngioma, as stated above, they come in 2 flavors, A. papillary and B. adamantinotomous. The kid type is the adamantinotomous form. These guys are calcified, papillary is not. These guys recur more, papillary does less, because it has a capsule. Buzzword is machinery oil. Hypothalamic hamartoma, a classic and mini. This is a hamartoma of the tuber cinereum, part of the hypothalamus located between the Marne-Miller bodies and the optic chiasm. They are TL and T2 ISO, and they do not enhance. The classic history is gelastic seizures, although precocious puberty is actually more common. Craniopharyngioma, shown on bone window. Calcifications in the SE/A. Hamartoma of the tuber cinereum. 167. Pineal region. There are three main characters here, all of which can present with vertical gaze palsy dorsal Parnot syndrome. Germinoma, the more common of the three, and seen almost exclusively in boys. Germinomas in the suprasellar region are usually in girls. Precocious puberty may occur from secretion of HCG. Characteristic findings are a mass-containing fat and calcification with variable contrast enhancement. It is heterogeneous on TL and T2 because of its mixed components. Pineoblastoma does occur in childhood. Unlike the pineocytoma, these guys are highly invasive. Some people like to think of these as PNETs in the pineal gland. They are associated with retinoblastoma. They are heterogeneous and enhance vividly. Pineocytoma, rare in childhood. Well circumscribed and non-invasive. Tend to be more solid, and the solid components do typically enhance. Calcification patterns in pineal tumors. Exploded pineocytoma, pineoblastoma. Engulfed germinoma. Pineal cyst and incidental findings that is meaningless, although frequently obsessed over. 168. L. Special topics, a few extra tips on characterization. Restriction. If they show a supralenloreal case with restriction, it's likely to be one of two things: 1, abscess, or 2, lymphoma. Technically, any hypercellular tumor can restrict GBM and medulloblastoma, but lymphoma is the one they classically show restricting. If it's a CP angle case, then it's an epidermoid. Lastly, a dirty move could be to show herpes encephalitis restricting in the temporal horns. Midline crossing. If they show it crossing the midline, it's most likely going to be a GBM or lymphoma. Alternatively, sneaky things they could show doing this would be radiation necrosis, a big MS plaque in the corpus callosum, or meningioma of the falx simulating a midline cross. Calcification. If they show it in the brain, it is probably an oligodendroglioma. The trick is that oligodendrogliomas calcify 90% of the time by CT and 100°/O by histopathology, whereas astrocytoma only calcify 20% of the time. But astrocytoma is very common and oligodendroglioma is not. So in other words, in real life it's probably still an astrocytoma. Intermediate. LTJ Bright. NF, 1 NF, 2 VA. VHLTSNE, oid basal cell syndrome, Gorlin, Tickett-Cowden's cold. Special topic syndromes. Optic nerve gliomas MSME, multiple schwannomas, meningiomas, ependymomas, ilemangioblastoma, brain and retina, subpendymal giant cell astrocytoma. Cortical tubers medu.lablastoma. GBM. Medulloblastoma Lermite-Duclos, dysplastic cerebellar gangliocytoma. Lermite-Duclos, DY, /plaslic cerebellar gang/IV Saloma. This thing is very uncommon. But when you see it, you need to have the following thoughts. Hey, that's Lenidal Dulcos. I guess she has Cowden syndrome. I guess she has breast CA. Next step. Mammogram. The appians is classic, with a tiger stripe. Mass, typically contained on one cerebellar hemisphere, occasionally crosses the venis. It's not a cancer, but actually a hamartoma, which makes sense since Cowden's is a hamartoma syndrome. 170. Section 6 trauma. Parenchymal. Parenchymal contusion, the rough part of the skull base can scrape the brain as it slides around in a high-speed MVA. Typical locations include the anterior temporal lobes and inferior frontal lobes. The concept of coup, site of direct injury, and contre-coup, opposite side of brain along vector of force. Contusion can look like blood with associated edema in the expected regions. Diffuse axonal injury/shear injury. There are multiple theories on why this happens, different density of white and gray matter, etc. They don't matter for practical purposes or for multiple choice. Things to know. Initial head CT is often normal. Favorite sites of dye are the posterior corpus callosum and GMWM junction in the frontal and temporal lobes. Multiple small T2 bright foci on MRI. Subarachnoid hemorrhage, trauma is the most common cause. Flare is the most sensitive sequence. This is discussed in more detail below. Subdural vs epidural. Subdural trauma patient, with a skull. Old man or alcoholic with an atrophic brain, who likes fracture to fall a lot, and stretch. I tear those bridging veins. Biconvex or lenticular. Biconcave, can cross the midline. Does not cross the midline. May extend into increment. Crick fissure, cannot cross a suture. Can cross a suture. Usually arterial, usually venous. Can rapidly expand and kill you. 171. The Leffert fracture pattern system. In the Dark Ages, René Leffert beat the shit out of cadavers with clubs and threw them off buildings. It was science. He then described 3 facial fracture patterns that interns in ENT and people who write multiple test questions think are important. It can be overly complicated, but the most common way a test question is written about these is either by asking the buzzword or the essential component. Frontal and temporal lobes. Multiple small T2 bright foci on MRI. Subarachnoid hemorrhage, trauma is the most common cause. Flare is the most sensitive sequence. This is discussed in more detail below. Subdural vs epidural. Subdural trauma patient, with a skull. Old man or alcoholic with an atrophic brain, who likes fracture to fall a lot, and stretch. I tear those bridging veins. Biconvex or lenticular. Biconcave, can cross the midline. Does not cross the midline. May extend into increment. Crick fissure, cannot cross a suture. Can cross a suture. Usually arterial, usually venous. Can rapidly expand and kill you. 171. The Leffert fracture pattern system. In the Dark Ages, René Leffert beat the shit out of cadavers with clubs and threw them off buildings. It was science. He then described 3 facial fracture patterns that interns in ENT and people who write multiple test questions think are important. It can be overly complicated, but the most common way a test question is written about these is either by asking the buzzword or the essential component. Buzzwords. LEF Ort 1, the palate separated from the maxilla, or floating palate. Leffert 2, the maxilla separated from the face, or pyramidal. Leffert 3, the face separated from the cranium. LE Forts. For dot, dash. Separated from the face, or pyramidal. Leffert 3, the face separated from the cranium. LE Forts. For dot, dash, underscore Leffert 2. Essential. Essential elements. All 3 fracture types share the pterygoid process fracture. If the pterygoid process is not involved, you don't have a Leffert. Each has a unique feature, which lends itself easily to multiple choice. Asterisk Leffert 1, lateral nasal aperture. Asterisk Leffert 2, inferior orbital rim, and orbital floor. Asterisk Leffert 3, zygomatic arch and lateral orbital rim/wall. Things to know about facial fractures. Nasal bone is the most common fracture. Zygomaticomaxillary complex fracture, tripod, is the most common fracture pattern, and involves the zygoma, inferior orbit, and lateral orbit. LE Fort fractures are both a stupid and a high-yield topic in facial trauma, for multiple choice. Floating palate equals 1, pyramidal equals 2, separated face equals 3. Transverse vs longitudinal temporal bone fractures. This classification system is stupid and outdated since most are mixed, and otic capsule violation is a way better predictive factor, but this is still extremely high yield. See chart on the next page. 173. 172. Mucocele. If you have a fracture that disrupts the frontal sinus outflow tract, usually nasal orbital ethmoid types, you can develop adhesions and obstruction of the sinus resulting in mucocele development. The buzzword is airless expanded sinus. They are usually TL bright, with a thin rim of enhancement. Tumors more often have solid enhancement. The frontal sinus is the most common location, occurring secondary to trauma, as described above. Temporal bone fractures, the traditional way to classify these is longitudinal and transverse, and this is almost certainly how the questions will be written. In the real world, that system is old and worthless, as most fractures are complex with components of both. The real predictive finding of value is violation of the otic capsule, as described in more modem papers. Longitudinal transverse. Long axis of T-bone, short axis off bone. More common, less common. More ossicular dislocation, more vascular injury, carotid eye jugular. Less facial nerve damage, around more facial nerve damage, 30%. 20%. More conductive hearing loss, more sensorineural hearing loss. Longitudinal transverse. 100. How old is that blood? This is an extremely high-yield topic. Maybe the most high-yield topic in all of neuro, with regard to multiple choice. The question can be asked with CT, or MRI, MRI more likely. If they do ask the question with CT, it's most likely to be the subacute subdural that is iso-intense to brain, with loss of sulci along the margins. They could also show the swirl sign, see below. Hyperacute acute, T hour, acute, 1 hour, 3 days. Subacute, 4 days, 3 weeks. Chronic, 3 weeks. Blood on CT. Hypodense. Hyperdense, progressively less dense, eventually becoming isodense to brain. Peripheral rim enhancement may occur with contrast. Hypodense. Swirl sign, this is an ominous sign of active bleeding. The central low attenuation blood represents hyperacute non-clotted blood, with surrounding acute clotted blood. MRI is more difficult to remember. Some people use the mnemonic IB, ID, BD, BB, DD, or it be itty bitty, baby, doo-doo, which I find very irritating. Instead of memorizing baby babbling noises, I use this graph showing a clockwise movement. This thing may seem tricky and too much to bear at first, but it does actually work, and once you draw it twice, you'll have it memorized. You'll also notice a few things. 1. You won't feel like a dipshit for making baby noises. 2. You'll have a renewed sense of self-esteem. And 3. You are likely to notice marked improvement in your golf swing. 0. /L. Intracellular met HB, early subacute, extracellular, late subacute. CD. Deoxy-HB, acute oxy-HB, hyperacute. 0 dash 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 dash. Hemo Hemorrhage, non-traumatic. Subarachnoid hemorrhage. Yes, the most common cause is trauma. A common point of trivia is that the most sensitive sequence on MRI for acute SAH is flare, because it won't suppress out, making it hyperintense. Be aware that supplemental oxygen, usually 50 to 100%, can give you a fake-out that looks like SAH on flare. When the blood is real, in the absence of trauma, there are a few other things to think about. Aneurysm, discussed below. Secuola of Sau. 1. 1. Hydrocephalus, early L. 2. Vasospasm, 7 to 10 days. 3. Superficial side Rossi's, late. Benign non-aneurysm perimesencephalic hemorrhage. This is a well-described entity, although not well understood. This is not associated with aneurysm, usually 95%, and may be associated with a venous bleed. The location of the blood, around the midbrain and pons without extension into the lateral sylvian cisterns or interhemispheric fissures is classic. Just think anterior to the brain stem. Rebleeding and ischemia are rare, and they do extremely well. Superficial side Rossi's. This is a side effect of repeated episodes of SAH. I like to think about this as staining the surface of the brain with hemosiderin. The classic look is curvilinear low signal on gradient coating the surface of the brain. The classic history is sensorineural hearing loss and ataxia. Superficial side Rossi's, hemosiderin staining. 176. L underscore. Intraparenchymal hemorrhage. Hypertensive hemorrhage, common locations are the basal ganglia, pons, and cerebellum. For the purpose of multiple choice tests, the basal ganglia is the most common location, specifically the putamen. You typically have intraventricular extension of blood. Amyloid angiopathy, history of an old dialysis patient, or some other history to think amyloid. The classic look is multiple lobes at different ages with scattered microbleeds on gradient. Septic emboli, these are seen in certain clinical scenarios, for drug user, organ transplant, cyanotic heart disease, AIDS patients, people with lung AVMs. The classic look is numerous small foci of restricted diffusion. Septic emboli to the brain result in abscess, mycotic aneurysms, most commonly in the distal MCAS, the location favors the gray-white interface and the basal ganglia. There will be surrounding edema around the tiny abscesses. The classic scenario should be parenchymal bleed in a patient with infection. Other random causes, this would include AVMs, vasculitis, brain tumors, primary, and METs. These are discussed in greater detail in various sections of the text. Intraventricular hemorrhage. Not as exciting. Just think about trauma, tumor, hypertension, AVMs, and aneurysms, all the usual players. Epidural subdural hemorrhage. Obviously these are usually post-traumatic. Duralofts and high-flow AVMs can bleed causing subdurals subarachnoid spaces. These are discussed further later in the chapter. 177. SECR10N1 vascular. Stroke is a high-yield topic. You can broadly categorize stroke into ischemic, 80%, and hemorrhagic, 20%. It's critical to remember that stroke is a clinical diagnosis, and that imaging findings complement the diagnosis. Watershed zones. Below is a diagram showing the various vascular territories. The junction between these zones is sometimes referred to as a watershed. These areas are prone to ischemic injury, especially in the setting of hypotension, or low oxygen states, near drowning, or Roger Gracie's cross-choke from the mount. Lenticulostriate. Gamesmanship. Watershed infarcts in a kid equals moya moya. Imaging signs on CT. Dense MCA sign lateroluminal thrombus is dense, usually in the MI and / or M2 segments. Insular ribbon sign loss of NOM1AL, high-density insular cortex from cytotoxic edema, loss of GMWM basal ganglia, I internal capsular region, and subcortical regions to TT errant Iotution mass effect peaks at 3 to 5 days. Enhancement rule OF3S, starts in 3 days, peaks in 3 weeks, gone by 3 months. 178. L. Fogging. This is a phase in the evolution of stroke when the infarcted brain looks like normal tissue. This is seen around 2 to 3 weeks post-infarct. Fogging is classically described with non-contrast CT, but T2 MRI sequences have a similar effect, typically occurring around day 10. In the real world, you could give for contrast to demarcate the area of infarct or just understand that fogging occurs. Imaging signs on MRI. Restricted diffusion. Acute infarcts usually are bright from about 30 minutes after the stroke to about 2 weeks. Restricted diffusion without bright signal on flare should make you think hyperacute, 6 hours. Not everything that restricts is a stroke. Bacterial abscess. CJD, cortical. Herpes, AP, lermoids, ilicoelar brain tumors, classic is lymphoma, acute MS lesions, oxyhemoglobin, and postultal states. Also artifacts, susceptibility, and T2 shine through. Enhancement. The rule of 3S is still useful. Enhancement starts around day 3, it peaks around 3 weeks, and is gone by 3 months. 0 to 6 hours, 6 to 24 hours minus 1 week diffusion, bright flare, not bright TL, LSO dark, with bright cortical necrosis. Necrosis T2 LSO bright. Hemorrhagic transformation. This occurs in about 50% of infarcts, with the typical time period between 6 hours and 4 days. If you got TPA, it's usually within 24 hours of treatment. People break these into 1. Tiny specks in the gray matter called petechial, which is the majority, 90%, and 2. Full-on hematoma, about 10%. Who gets it? People on anticoagulation, people who get TPA, people with embolic strokes, especially large ones, venous infarcts. Predictors of hemorrhagic transformation in patients getting TPA. Multiple strokes, proximal MCA occlusion, greater than 1/3 of the MCA territory, greater than 6 hours since onset, delayed recanalization, absent collateral flow. 179. Venous infarct. Not all infarcts are arterial. You can also stroke secondary to venous occlusion, usually the sequelae of dural venous sinus thrombosis, or deep cerebral vein thrombosis. In general, venous infarcts are at higher risk for hemorrhagic transformation. In little babies think dehydration, in older children think about mastoiditis, in adults think about coagulopathies, protein C, and SDEF, and oral contraceptives. The most common site of thrombosis is the sagittal sinus, with associated infarct occurring 75% of the time. Venous thrombosis can present as a dense sinus, or empty delta on contrast. Venous infarcts tend to have heterogeneous restricted diffusion. Venous thrombosis can result in vasogenic edema that eventually progresses to stroke and cytotoxic edema. Arterial stroke equals cytotoxic edema. Venous stroke equals vasogenic edema plus cytotoxic edema. Stigmata of chronic venous thrombosis include the development of AA dural AVF, or increased CSF pressure from impaired drainage. 180. Aneurysm. Coagulopathies, protein C and SDEF, and oral contraceptives. The most common site of thrombosis is the sagittal sinus, with associated infarct occurring 75% of the time. Venous thrombosis can present as a dense sinus, or empty delta on contrast. Venous infarcts tend to have heterogeneous restricted diffusion. Venous thrombosis can result in vasogenic edema that eventually progresses to stroke and cytotoxic edema. Arterial stroke equals cytotoxic edema. Venous stroke equals vasogenic edema plus cytotoxic edema. Stigmata of chronic venous thrombosis include the development of AA dural AVF, or increased CSF pressure from impaired drainage. 180. Aneurysm. Who gets them? People who smoke, polycystic kidney disease, connective tissue disorders, Marfan's, Ehlers-Danlos, people with aortic coarctation, NF, FMD, and AVMs. Where do they occur? They occur at branch points. Why do persistent trigeminals get more aneurysms? Because they have more branch points. They favor the anterior circulation, 90%, with the anterior communicating artery being the most common site. As a piece of random trivia, the basilar is the most common posterior circulation location, pica origin is the second most common. When do they rupture? Rupture risk is increased with size, a posterior location, history of prior SAH, smoking history, and female gender. Which one did it? A common dilemma is SAH in the setting of multiple aneurysms. The things that can help you are location of the SAH/clot, location of the vasospasm, size, and which one is the most irregular, focal outpouching, Murphy et al. 181. Aneurysm types, saccular, Berry the most common type. They are commonly seen at bifurcations. The underlying pathology may be a congenital deficiency of the internal elastic lamina and tunica media at branch points. Remember that most are idiopathic, with the associations listed above. They are multiple L5 to 20% of the time. Fusiform aneurysm, associated with PAN, connective tissue disorders or syphilis. These more commonly affect the posterior circulation. May mimic a CPA mass. Pseudoaneurysm, think about this with an irregular, often saccular, arterial outpouching at a strange atypical location. You may see focal hematoma next to the vessel on non-contrast. Traumatic, often distal secondary to penetrating trauma, or adjacent fracture. Mycotic, often distal, most commonly in the MCA, with the associated history of endocarditis, meningitis, or thrombophlebitis. Pedicle aneurysm, aneurysm associated with an AVM. The trivia to know is that it's found on the artery feeding the AVM, 15% of the time. These may be higher risk to bleed than the AVM itself, because they are high flow. Blister aneurysm, this is a sneaky little dude, the angio is often negative. It's broad-based at a non-branch point, supraclinoid ICA is the most common site. Infundibular widening, not a true aneurysm, but instead a funnel-shaped enlargement at the origin of the P. posterior communicating artery at the junction with the ICA. Thing to know is not greater than 3 mm. Saccular, berry. Fusiform pedicle aneurysm, mycotic blister aneurysm. Branch points in the anterior circulation, posterior circulation artery feeding the AVM, distal MCAS, broad-based non-branch point, supraclinoid ICA, ACM PCOM. Maximum bleeding, aneurysm location, ultraatmospheric efficeral psiliteral basal cistern, MCA trifurcation, Sylvian Fisher basilar tip, ultrapeduncular cistern, or intraventricular. Pica posterior fossa, or ultraventricular. AVM associated. Flow related, I feeder ipedic aneurysm equals 15%. Ultranidal aneurysm, 50%. 182. L. Vascular malformation. Malformation. There are 6 different kinds, and I will actually touch on all 6, some in more detail than others. 1. High-flow AVMs. This is the most common type of high-flow lesion. They favor a supratentorial location, and are the result of a congenital malformation in the development of the capillary bed. As the name, high flow, implies there is an arterial component, nidus, draining veins. Hemorrhage is the most common complication, headache is the most common symptom. Bleeding has an incidence of about 3% per year. Seizure would be the second most common complication, and the adjacent brain may be atrophic and gliotic. Increased bleeding risk, small size of AVM, actually higher pressure, single draining vein, intranidal/perinidal aneurysm, basal ganglia/thalamic/periventricular locations. 2. Dural AVF. These can be high flow or low flow. They are less common than the high flow AVMs. Unlike AVM, these are thought to be acquired secondary to dural sinus thrombosis. Unlike AVMs, there is no nidus. These present in the 50s to 60s, AVMs present in 20s to 30s. Classic symptom is pulsatile tinnitus, when it involves the sigmoid sinus. May have vision problems if the cavernous sinus is involved. Increased bleeding risk, direct cortical venous drainage. Can be occult on RIMRA, need catheter angio if suspicion high. SBINAL AVFs are actually the most common type of AVFs. A helpful hint is the classic clinical history of gradual onset LE weakness. 3. DVA. This is not actually a vascular malformation, just a variation in normal venous drainage. If you tried to resect one, you would end up with a nice venous infarct. Some buzzwords are caput medusa, or a large tree with multiple small branches, to describe its appearance. The big thing to remember is the association with cavernous malformations. 4. Cavernous malformation. These things are also called cavemomas and cavernous angiomas. These are low-flow lesions with a dilated capillary bed without intervening normal brain tissue. They can be single or multiple, more common in Hispanics. Buzzword is popcorn-like with peripheral rim of hemosiderin. Look for them on gradient because of the hemosiderin. They can ooze some blood, but typically don't have full-on catastrophic bleeds. As mentioned above, they may have a nearby DVA. 183. 5. Capillary telangiectasia. This is another slow-flow lesion that, unlike the cavernoma, does have intervening normal brain tissue. They don't bleed and are usually totally incidental. The most common look for this is a single lesion in the pons. Again, these are best seen on gradient, slow flow, and deoxyhemoglobin. The buzzword is brush-like or stippled pattern of enhancement. Key high-yield fact is that these can develop as a complication of radiation therapy. 6. Mixed. This is a wastebasket term, most often used for DVA with AV shunting or DVAs with telangiectasias. Vasospasm. Vessels do not like to be bathed in blood, SAH, it makes them freak out, spasm. The classic timing for this is 4 to 14 days after SAH, not immediately. It usually looks like smooth, long segments of stenosis. It typically involves multiple vascular territories. It can lead to stroke. Who gets it? It's usually in patients with SAH, and the more volume of SAH the greater the risk. In 1980 some neurosurgeon came up with this thing called the Fisher score, which grades vasospasm risk. The gist of it is greater than 1 mm in thickness, or intraventricular hyperenchimal extension is at higher risk. Are there non-SAH causes of vasospasm? Yep. Meningitis, prez, and migraine headache. Critical take-home point, vasospasm is a delayed side effect of SAH. It does not occur immediately after a bleed. You see it 4 to 14 days after SAH. Vascular dissection. Vascular dissection can occur from a variety of etiologies, usually penetrating trauma, or a trip to the chiropractor. Penetrating trauma tends to favor the carotids, and blunt trauma tends to favor the vertebrals. Vertebrals. This would be way too easy to show on CT as a flap, so if it's shown it's much more likely to be the TL bright crescent sign, or intramural hematoma. Crescent sign of dissection, it's the T1 bright intramural blood. 184. Vasculitis. You can have a variety of causes of CNS vasculitis. One way to think about it is By clumping it into A. Primary CNS vasculitis, B. Secondary CNS vasculitis. Vasculitis from infection, or sarcoid, C. Systemic vasculitis with CNS involvement, and D. CNS vasculitis from a systemic disease. Primary CNS vasculitis, primary angiitis of the CNS, PA CNS. Secondary CNS VA, cheilitis meningitis, bacterial, TB, fungal. Septic from infection, or sarcoid embolus, sarcoid. Systemic vasculitis with PAN. Temporal arteritis, Wegner's, Takeisos. CNS involvement, CNS vasculitis from a cocaine use. RA, SLE, Lyme systemic disease. They all pretty much look the same with multiple segmental areas of vessel narrowing, with alternating dilation, beaded appearance. You can have focal areas of vascular occlusion. Trivia. PAN is the most common systemic vasculitis to involve the CNS, although it is a late finding. SLE is the most common collagen vascular disease. Miscellaneous vascular conditions. Moya moya, this non-atherosclerotic poorly understood entity, originally described in Japan, hence the name, is characterized by progressive stenosis of the supraclinoid, ICA eventually leading to occlusion. The progressive stenosis results in an enlargement of the basal perforating arteries. Things to know. Buzzword equals puff of smoke for angiographic appearance watershed distribution in a child. Think sickle cell. Other notable associations include NF, prior radiation, Down syndrome, bimodal age distribution, early childhood, and middle age, children stroke, adults bleed. 185. Cadasal, cerebral autosomal dominant. dominant arteriopathy with subcortical infarcts and leukoencephalopathy. Think about a 40-year-old presenting with migraine headaches, then eventually dementia. The MRI will show severe white matter disease involving multiple vascular territories in the frontal and temporal lobe. The occipital lobes are often spared. Cadasal, diffuse white matter disease, hitting the temporals, sparing occipitalis. NACIT criteria, the North American Symptomatic Carotid Endarterectomy Trial, NACIT, criteria, is used for carotid stenosis. The rule is, measure the degree of stenosis using the maximum internal carotid artery stenosis VA compared to a parallel, non-curved, segment of the distal, cervical internal carotid artery B. You then use the formula 1A/B x 100%. A 1 x 100B minus 0. 186. SEC 110NA developmental. Congenital malformations is a very confusing and complicated topic, full of lots of long Latin and French-sounding words. If we want to keep it simple and somewhat high yield, you can look at it in 6 basic categories. 1. Failure to form. 2. Failure to cleave. 3. Failure to migrate. 4. Normal forming but massive insult makes you look like you didn't form. 5. Herniation syndromes. And 6. Craniosynostosis. Failure to form. A classic point of trivia is that the corpus callosum forms front to back, then rostrum last. Therefore hypoplasia of the corpus callosum is usually absence of the splenium, with the genu intact. With agenesis of the corpus callosum, a common trick is to show colpocephaly, asymmetric dilation of the occipital horns. 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 When you see this picture, you should say 2 things. 1. Corpus callosum agenesis. 2. Caricallosal lipoma. Colpocephaly, asymmetric dilation of the occiput. 187. Callosal dysgenesis iagenesis. This is associated with lots of other syndromes/malformations, lipoma, heterotopias, schizencephaly, lysencephaly, etc. Most common anomaly seen with other CNS malformations. If they ask this, it will either be the colpocephaly picture, the steer horn appearance of cornel, or the vertical ventricles widely spaced, racing car, on axial. Vertical ventricles, widely spaces. Why are the lateral ventricles widely spaced when you have no corpus callosum? There are these things called Probst bundles, which are densely packed WM tracks, destined to cross the CC, but can't because it isn't there. So instead they run parallel to the interhemispheric fissure. 187. Callosal dysgenesis iagenesis. This is associated with lots of other syndromes/malformations, lipoma, heterotopias, schizencephaly, lysencephaly, etc. Most common anomaly seen with other CNS malformations. If they ask this, it will either be the colpocephaly picture, the steer horn appearance of cornel, or the vertical ventricles widely spaced, racing car, on axial. Vertical ventricles, widely spaces. Why are the lateral ventricles widely spaced when you have no L. L. Anencephaly, neural tube fails to close on the cranial end leading to reduced or absent cerebrum and cerebellum. The hindbrain will be present. Obviously this is not compatible with life. Trivia, AFP will be elevated, polyhydramnios will be present, hard to swallow without a brain. If they show it, it will have to be antenatal ultrasound, and will likely be polyhydramnios plus the incredibly creepy, frog eye appearance on the coronal plane, due to absent cranial bone eye brain with bulging orbits. Iniencephaly, rare neural defect with the main features including deficit of the occipital bones. This results in an enlarged foramen magnum. These guys also have really jacked up spines. Stargazing fetus is the buzzword because they are contorted in a way that makes their face tum upward, hyperextended cervical spine, short neck, and upturned face. Rhinencephaly, no olfactory bulb. Bulbs and tracks. Seen with Kalman's syndrome, hypogonadism, mental retardation. Retardation. Rhombencephalosynapsis, congenital anomaly of the cerebellum, where the vermis doesn't develop and instead you just fuse your cerebellum. Classically a transversely oriented single-lobed cerebellum is shown, this is an Ant Mini. Joubert syndrome, okay, so this is another Ant Mini, because of the molar tooth appearance of the superior cerebellar peduncles, they are elongated like the roots of a tooth. There is going to be a small or a plastic cerebellar vermis, and there will be absence of pyramidal decussation. It has a strong association, 50%, with retinal dysplasia. There is also an association with multicystic dysplastic kidneys, 30%. When you see it in combination with liver fibrosis, it's a total zebra, near unicorn, called Koch syndrome. Rhombencephalosynapsis, note the vertical line across the cerebellum. Joubert molar tooth. 189. Dandy Walker. Radiologists love to nitpick and obsess over details. Usually, the more meaningless the detail, the more ferocious the debate. Along those lines, this is a spectrum that leads to much confusion and argument. For the purpose of the multiple choice tests, I would just say that Dandy Walker equals absent vermis. The buzzword is torcular lambdoid inversion. The torca/AR is above the level of the lambdoid due to abnormally high tentorium. The following chart is just for the sake of addressing the ridiculousness of this posterior fossa situation. It ought to be very low yield for the exam, which probably means it is high yield. It may also be useful if you want to join in the debate. Morphology, most severe, least severe, ventriculocele, DWM variant. Classic, DWM. Variant, DWM. Persistent Blake pouch. Megasisterna mag. Magna. Cystic L. Underscore failure to cleave. Holoprosencephaly. Hope this is a midline cleaving problem with the brain failing to cleave into two separate hemispheres. The cleavage apparently occurs back to front, opposite of the formation of the corpus callosum, so in milder forms the posterior cortex is normal and the anterior cortex is fused. It is classified as a spectrum. Lobar - plus semilobar. A lobar, most severe. Lobar, mild, semilobar. A lobar, severe. Right and left hemispheres are separate, anterior/inferior frontal still sometimes fused. Basic structure present but there is a single large. May be limited to absent septum pellucidum. Pituitary problems are common. Fused at the thalami. Ventricle, with fusion of the posterior brain is normal. Thalami and basal ganglia. Olfactory tracts and bulbs no fakes. No corpus callosum. Arc gone. The old saying face predicts brain, but brain doesn't predict face, is actually mostly true. In other words, monster cyclops babies usually have some midline defect, holoprosencephaly. There are several other associations that are frequently shown. L. Underscore Lobar dash plus semilobar. A lobar, most severe. Lobar, mild, semilobar. A lobar, severe, right and left hemispheres are separate, anterior/inferior frontal still sometimes fused. Basic structure present but there is a single large. May be limited to absent septum pellucidum. Pituitary problems are common. Fused at the thalami. Ventricle, with fusion of the posterior brain is normal. Thalami and basal ganglia. Olfactory tracts and bulbs no fakes. No corpus callosum. Arc gone. The old saying face predicts brain, but brain does one predict face is actually mostly true. In other words, monster cyclops babies usually have some midline defect, holoprosencephaly. There are several other associations that are frequently shown and often testable. HPE associations. Single midline monster eye, solitary median maxillary incisor, mega incisor, nasal process overgrowth leading to pyriform aperture stenosis. Meckel-Gruber syndrome, classic triad, O holoprosencephaly, O multiple renal cysts, and O polydactyly. 191. Anencephaly, this actually means no brain. Brain. It is classified as a spectrum. Classified as a spectrum. Anencephaly, this actually means no brain. This is basically the extreme end of the holoprosencephaly spectrum. You are going to have no brain, only a brainstem, no skull, and no scalp. See the reproductive chapter in volume 1 for more on this. Failure to migrate, I proliferate. Hemimegalencephaly, rare but unique, Ant mini, malformation characterized by enlargement, from hamartoma overgrowth, of all or part/s of one cerebral hemisphere. The cause of this condition is speculated to be a problem of neuronal differentiation and cell migration in a single hemisphere. The affected hemisphere may have focal or diffuse neuronal migration defects, including areas of polymicrogyria, pachygyria, and heterotopia. Here is the trick, look at which side, the big side or the little side, has the ventriculomegaly. Small side plus big ventricle equals atrophy, as might be seen with Rasmussen encephalitis. Big side plus big ventricle equals hemimegalencephaly, big side, big ventricle. Buzzword, hamartoma 2 overgrowth of all or part of a cerebral hemisphere. Lissencephaly pachygyria spectrum, the spectrum of diseases that cause relative smoothness of the brain surface. Vocabulary includes agyria, no gyri, pachygyria, broad gyri, and lissencephaly, smooth brain surface. You can think about it as either. Type 1/classic form equals smooth brain. This results from arrest of migration. Buzzwords include figure 8, hourglass appearance, vertically oriented shallow sylvian fissures. This one is associated with band heterotopias. Type 2 as a cobblestone brain. This results from overmigration. There is not band heterotopia, and the cortex is thinner than type I. 192. L. L. L subependymal, most common, gray matter heterotopias, normal neurons in abnormal locations. These guys can be grouped and then subgrouped into groups. Nodular / gray matter heterotopia. I diffuse / subcortical. Band double cortex. Lissencephaly. Laminar. They are associated with other congenital neurologic conditions. A random point of trivia. If you are trying to compare subependymal heterotopias with the subependymal tubers of TS, the tubers are usually higher on T2 signal than gray matter and are often calcified, except in early childhood. Schizencephaly, migrational disorder that results in a gray matter-lined cleft that will extend through the entire hemisphere. It comes in two main flavors, 1, closed lip, 20%, and 2, open lip, 80%. Highly testable associations, optic nerve hypoplasia, 30%, absent septum pellucidum, 70%, epilepsy, demonic possession, 50 to 80%. Classic this vs that, porencephalic Cyst vs. open lip schizencephaly. They look very similar, but the schizencephalic cleft should be lined with gray matter and is a true malformation. The porncephalic cyst is just a hole from a prior encephaloclastic event, ischemia. Normal forming but massive insult makes you look like you didn't form. Hydranencephaly, devastating condition characterized by destruction of the cerebral hemispheres. Basically this turns the skull into a bag of CSF. It is thought to be secondary to a vascular insult in utero, think double MCA infarct. This could be seen in the setting of a torch causing a necrotizing vasculitis, HSV does this. The key point is that you did have a normal brain, so you have a falx, but the cortical mantle is gone. 193. Lots of CSF brain strategy. Whoa. That's a lot of CSF. CSF. Hydranencephaly. L. Herniation syndrome vocab. Cephaloceles, herniation of the cranial contents through a defect in the skull. Meningoencephalocele, brain and meninges meningocele, just meninges, no brain. Chiari malformations. Chiari malformation essentially occurs because of a mismatch between size and content of the posterior fossa. Type 1, these guys have headaches. Criteria is 1 cerebellar tonsil more than SMM below the foramen magnum. This is often accompanied by crowding of the posterior fossa, and you should look for syringohydromyelia, seen in about 50% of cases. As you age, the tonsils ascend, so 3 mrn below the foramen in a 90-year-old would be abnormal. There are several associations, but the one that is most often asked is with Klippel-Feil syndrome, congenital C-spine fusion. Type 2, this type is more complicated and there are like 20 findings. Hydrocephalus is found in more than 90% of cases. I'm going to try and pick the 5 I think they are most likely to ask or show. Myelomeningocele, lumbar spine towering cerebellum tectal plate beaking long skinny fourth ventricle, elongated craniocaudally, short in other dimensions, a normal fourth ventricle may suggest shunt malfunction in terdigitate cerebral gyri, most likely shown on axial CT, single image. Type 3, just think Chiari2 plus encephalocele, either high cervical or low occipital, tectal beaking Chiari2. 195. Craniosynostosis. Premature fusion of one or more of the cranial sutures can result in a weird-shaped head. I have just a few high-yield points regarding the subject. Scaphocephaly, sagittal suture, is the most common subtype and is often referred to as dolichocephaly. Brachycephaly, cornal and / or lambdoid, is often associated with syndromes. Of course they are all zebras but a few are worth knowing. Aperts, brachycephaly and fused fingers Crouzens, usually brachycephali, but not always, plus first arch maxilla and mandible hypoplasia. Cletocranial dysostosis, brachycephaly and Wormian bones and absent clavicles. Plagiocephaly can result from unilateral cornal or lambdoid suture fusion, frontal or occipital plagiocephaly. Ipsilateral cornal fusion can elevate the superior orbital wall and cause a harlequin eye. Brachycephaly bicornal and / or bilambdoid. Metopic. Cornal. Sagittat. -- Lambdoid. Gigocephagy scaphocephaly unilateral cornal suture sagmet suture trigonocephaly metopic suture. 196. L high yield trivia I buzzwords for craniosynostosis. Most common type equals sagittal, dolichocephaly or scaphocephaly, sagittal suture craniosynostosis almost always 80%, AF text boys cornal suture craniosynostosis affects more girls. Ilerlequini equals unilateral cornal suture craniosynostosis, lift supraorbital margin. Margin. Lambdoid craniosynostosis favors the right side, 70%, pterocephaly, the tower, is from both cornal and lambdoid fusion. Gamesmanship, sinus paracranii. A rare disorder that can be shown as a focal skull defect with an associated vascular malformation. The underlying pathology is a low-flow vascular malformation, which is a communication between a dural venous sinus, usually the superior sagittal, and an extracranial venous structure via the emissary veins. Most likely way to show this. 1. MRI with some type of vascular sequence, post-con, or MRA, FOF. 2. CT showing the skull defect, wanting a next step, ultrasound or MRL to demonstrate the vascular component. 197. Section 9. Section 9, Miscellaneous PEDS Neuro. Enlarged extraaxial fluid spaces. Extraaxial fluid spaces are considered enlarged if greater than 5 mm. BESI is the name people throw around for benign enlargement of the subarachnoid space in infancy. The etiology is supposed to be immature villa, that's why you grow out of it. BES/trivia. 1. It's the most common cause of macrocephaly. 2. It typically resolves after 2 years with no treatment. 3. There is an increased risk of subdural bleed, either spontaneous or with a minor trauma. BESI vs subdural collection. BESI cortical veins are adjacent to the inner table. Subdural cortical veins are displaced away from the inner table. Trivia. Premature kids getting tortured on ECMO often get enlarged extraaxial spaces. This isn't really the same thing as BESI and more related to fluid changes I stress. Choanal atresia. This is a malformation of the choanal openings. Buzzwords are failure to pass NG tube and respiratory distress while feeding. Neonates have to breathe through their noses. It's usually unilateral, 2/3. There are two different types, bony, 90%, and membranous, 10%. The appearance is a unilateral or bilateral posterior nasal narrowing, with thickening of the vomit. There are a bunch of syndromic associations, Charge, Crouzens, DeGeorge, Treacher-Collins, and fetal alcohol syndrome. Piriform aperture stenosis, this can occur in isolation, or with choanal atresia. The big thing to know is the high association with hypothalamic pituitary adrenal axis dysfunction. MELAS, this is a mitochondrial disorder with lactic acidosis and stroke-like episodes. The SPECT question is always, increased lactate. Lactate, decreased Na. Leukodystrophies. Leukodystrophies, these are zebra disorders that affect the white matter in kids. Section 9, Miscellaneous PEDS Neuro. Enlarged extraaxial fluid spaces. Extraaxial fluid spaces are considered enlarged if greater than 5 mm. BESI is the name people throw around for benign enlargement of the subarachnoid space in infancy. The etiology is supposed to be immature villa, that's why you grow out of it. BES/trivia. 1. It's the most common cause of macrocephaly. 2. It typically resolves after 2 years with no treatment. 3. There is an increased risk of subdural bleed, either spontaneous or with a minor trauma. BESI vs subdural collection. BESI cortical veins are adjacent to the inner table. Subdural cortical veins are displaced away from the inner table. Trivia. Premature kids. Kids getting tortured on ECMO often get enlarged extraaxial spaces. This isn't really the same thing as BESI and more related to fluid changes I stress. Choanal atresia, this is a malformation of the choanal openings. Buzzwords are failure to pass NG tube and respiratory distress while feeding. Neonates have to breathe through their noses. It's usually unilateral, 2/3. There are two different types, bony, 90%, and membranous, 10%. The appearance is a unilateral or bilateral posterior nasal narrowing, with thickening of the vomit. There are a bunch of syndromic associations, Charge, Crouzens, DeGeorge, Treacher-Collins, and fetal alcohol syndrome. Piriform aperture stenosis, this can occur in isolation or with choanal atresia. The big thing to know is the high association with hypothalamic pituitary adrenal axis dysfunction. MELAS, this is a mitochondrial disorder with lactic acidosis and stroke-like episodes. The SPECT question is always, increased lactate, decreased Na. Leukodystrophies, these are zebra disorders that affect the white matter in kids. If you See a brain MRI on a kid with jacked up white matter, you should be thinking about one of these guys. The distinction between them is totally academic, since they are all untreatable and fatal. Here are my tricks. Canavans is always shown with spect, with an elevated gnaw. Alexander's has a big head, like Alexander the Great, and has frontal white matter involvement, frontal because of his personality disorder, metaphorically speaking. Metachromatic is the most common, and the buzzword is tigroid. Tigroid refers to dark spots or stripes within the T2, bright demyelinated periventricular white matter. 198. Head size, age, territory. Trivia. Metachromatic normal head infantile FOM11-2 diffuse white most common yo. Juvenile form matter leukodystrophy 5 to 7 involvement, with deficiency of tigroid the enzyme appearance. Aryl sulfatase A. Adurkno normal head 5 to 10 yo. Symmetric sex-linked leukodystrophy occipital and recessive splenium of condition corpus callosum, peroxisomal white matter enzyme involvement. Deficiency, occurring only in boys. Lee disease normal head less than 5 yo. Focal areas of also called subcortical white subacute matter. Basal necrotizing ganglia and encephaloperiaqueductal myelopathy. Gray matter mitochondrial involvement. Enzyme defect. Alexander big head less than I yo. Frontal white disease matter involvement. Involvement. Canavan disease. Disease big head less than I yo. Yo. Diffuse bilateral elevation. Section 10, MRI SPECT. The highest normal peak is Na. The Na peak will be super high with Canavans. Choline is elevated in anything that causes cell turnover, tumor, infarct, or inflammation. Lactate and lipid peaks superimpose. You need to use an intermediate T, around 140, to causes an inversion of the lactate peak, so you can see it. Lactate lipid peak has a characteristic double peak at a long T, around 280. A normal adult head should not have a lactate peak. It's a marker of aerobic metabolism. So you see it in necrotic tumors, HLGH grade, and infection, cerebral abscess. It's normal to see lactate elevated in the first hours of life. Remember, exceptions to rules are always high-yield myoinositol is elevated with Alzheimer's, and low-grade gliomas. Alanine elevation is specific for meningiomas. Meningiomas do not have elevated Na. Glutamine is elevated in hepatic encephalopathy. High-grade tumor equals choline up, Na down, lactate and lipids up. Low-grade tumor equals choline down, Na down, inositol up, radiation necrosis pattern, choline down, Na down, lactate up. ./nm-creatine. /choline. Normal. The highest normal peak is Na. The Na peak will be super high with Canavans. Choline is elevated in anything that causes cell turnover, tumor, infarct, or inflammation. Lactate and lipid peaks superimpose. You need to use an intermediate T, around 140, to causes an inversion of the lactate peak, so you can see it. Lactate lipid peak has a characteristic double peak at a long T, around 280. A normal adult head should not have a lactate peak. It's a marker of aerobic metabolism. So you see it in necrotic tumors, HLGH grade, and infection, cerebral abscess. It's normal to see lactate elevated in the first hours of life. Remember, exceptions to rules are always high-yield myoinositol is elevated with Alzheimer's, and low-grade gliomas. Alanine elevation is specific for meningiomas. Meningiomas do not have elevated Na. Glutamine is elevated in hepatic encephalopathy. High-grade tumor equals choline up, Na down, lactate and lipids up. Low-grade tumor equals choline down, Na down, inositol up, radiation necrosis pattern, choline down, Na down, lactate up. /NM-creatine /choline. Normal. Lactate would be down here. would be down here I1T choline FIT 199. Section 10, MRI SPECT. The highest normal peak is Na. The Na peak will be super high with Canavans. Choline is elevated in anything that causes cell turnover, tumor, infarct, or inflammation. Lactate and lipid peaks superimpose. You need to use an intermediate T, around 140, to causes an inversion of the lactate peak, so you can see it. Lactate lipid peak has a characteristic double peak at a long T, around 280. A normal adult head should not have a lactate peak. It's a marker of aerobic metabolism. So you see it in necrotic tumors, HLGH grade, and infection, cerebral abscess. It's normal to see lactate elevated in the first hours of life. Remember, exceptions to rules are always high-yield myoinositol is elevated with Alzheimer's, and low-grade gliomas. Alanine elevation is specific for meningiomas. Meningiomas do not have elevated Na. Glutamine is elevated in hepatic encephalopathy. High-grade tumor equals choline up, Na down, lactate and lipids up. Low-grade tumor equals choline down, Na down, inositol up, radiation necrosis pattern, choline down, Na down, lactate up. /NM-creatine /choline. Normal. Lactate would be down here I1T choline FIT III. Notice that choline, creatine, and Na fall in alphabetical order. That makes it easy to remember which is which. Vocab, the normal dotted line is called Hunter's angle. GBM 200 L. Inflammation. Lactate and lipid peaks superimpose. You need to use an intermediate T, around 140, to causes an inversion of the lactate peak, so you can see it. Lactate lipid peak has a characteristic double peak at a long T, around 280. A normal adult head should not have a lactate peak. It's a marker of aerobic metabolism. So you see it in necrotic tumors, HLGH grade, and infection, cerebral abscess. It's normal to see lactate elevated in the first hours of life. Remember, exceptions to rules are always high-yield myoinositol is elevated with Alzheimer's, and low-grade gliomas. Alanine elevation is specific for meningiomas. Meningiomas do not have elevated Na. Glutamine is elevated in hepatic encephalopathy. High-grade tumor equals choline up, Na down, lactate and lipids up. Low-grade tumor equals choline down, Na down, inositol up, radiation necrosis pattern, choline down, Na down, lactate up. /NM- creatine /choline. Normal. Lactate would be down here I L. Section 11, temporal bone. 1. Petrous apex. Anatomic variation. Variation can occur in the amount of pneumatization, marrow fat, bony continuity, and vascular anatomy. Asymmetric marrow. Typically the petrous apex contains significant fat, closely following the scalp and orbital fat, TL and T2 bright. When it's asymmetric you can have two problems. 1. Falsely thinking you've got an infiltrative process, when you don't, and 2. Overlooking a TL bright thing, cholesterol granuloma, thinking it's fat. The key is to use stir or some other fat-saturating sequence. Cephaloceles. A cephalocele describes a herniation of CNS content through a defect in the cranium. In the petrous apex they are a slightly different animal. They don't contain any brain tissue, and simply represent cystic expansion and herniation of the posterolateral portion of Meckel's cave into the supramedial aspect of the petrous apex. Describing it as a herniation of Meckel's cave would be more accurate. These are usually unilateral, and are classically described as smoothly marginate lobulated cystic expansion of the petrous apex. Variant anatomy of the carotid artery. The two main variants to be aware of are the persistent stapedial artery and aberrant internal carotid. For the purpose of the exam the only things to know are don't biopsy them, they aren't glomus tympanicum tumors, and they can give pulsatile tinnitus. 201. Inflammatory lesions. Cholesterol granuloma, the most common primary petrous apex lesion. Mechanism is likely obstruction of the air cell, with repeated cycles of hemorrhage and inflammation leading to expansion and bone remodeling. The most common symptom is hearing loss. On CT the margins will be sharply defined. On MRI it's gonna be TL and T2 bright, with T2 dark hemosiderin rim, and faint peripheral enhancement. The slow-growing ones can be watched. The fast-growing ones need surgery. Key point, cholesterol granuloma equals TL and TL bright. Cholesterol granuloma equals T1 and T2 bright. Cholesteatoma, this is basically an epidermoid, ectopic epithelial tissue. They are congenital, not acquired, in the petrous apex. They are typically slow-growing, and produce bony changes similar to cholesterol granuloma. The difference is their MRI findings, TL dark, T2 bright, and restricted diffusion. O key point, cholesteatoma equals TL dark, TL bright, restricted diffusion. Cholesterol granuloma TL bright T2 bright doesn't restrict smooth expansile bony change. Cholesteatoma TL dark T2 bright does restrict smooth expansile bony change. 202. L. Apical petrositis, infection of the petrous apex, is a rare complication of infectious otomastoiditis. It can have some bad complications if it progresses, including osteomyelitis of the skull base, vasospasm of the ICA, if it involves the carotid canal, subdural empyema, venous sinus thrombosis, temporal lobe stroke, and full-on meningitis. In children, it can present as a primary process. In adults, it's usually in the setting of chronic otomastoiditis or recent mastoid surgery. Apical petrositis. Grady-Oigo syndrome, this is a complication of apical petrositis when Dorello's canal, CN6, is involved. They will show you or tell you that the patient has a lateral rectus palsy. The classic triad equals otomastoiditis, face pain, trigeminal neuropathy, and lateral rectus palsy. 203. Tumors. Endolymphatic sac tumor, rare tumor of the endolymphatic sac and duct. Although most are sporadic, when you see this tumor you should immediately think von Hippel-Lindau. They usually grow into the CPA. They almost always have internal amorphous calcifications on CT. There are T2 bright, with intense enhancement. They are very vascular, often with flow voids and tumor blush on angiography. Paraganglioma, on occasion, paraganglioma of the jugular fossa, glomus jugulare, or jugulotympanic tumors, can invade the occipital bone and adjacent petrous apex. As much as 40% of the time it's hereditary, and they are multiple. The most common presenting symptom is hoarseness from vagal nerve compression. They are very vascular masses, they enhance avidly with a salt and pepper appearance on post-contrast MRI, with flow voids. They are FDG avid. 204. L. Inner ear. Congenital. Large vestibular aqueduct syndrome. The vestibular aqueduct is a bony canal that connects the vestibule, inner ear, with the endolymphatic sac. When this becomes enlarged, 1.5 millimeters, it is associated with progressive sensorineural hearing loss. As a point of trivia, the large vestibular aqueduct syndrome is associated with an absence of the bony modiolus in more than 90% of patients. This has an mini appearance. Supposedly this is the result of failure of the endolymphatic sac to resorb endolymph, leading to endolymphatic hydrops and dilation. Trivia: this is the most common cause of congenital sensorineural hearing loss. The finding is often, usually, bilateral. There is an association with cochlear deformity, near 100% progressive sensorineural hearing loss. They are not born deaf. The normal VA is never larger than the adjacent PSCC, enlarged vestibular aqueduct. 205. Infections. Labyrinthitis. This is an inflammation of the membranous labyrinth, most commonly the result of a viral infection. The cochlea and semicircular canals will be shown enhancing on TL post-contrast imaging. Labyrinthitis ossificans, gamesmanship, history of childhood infection/meningitis. You see it in kids, ages 2 to 18 months. They will show this on CT, with ossification of the membranous labyrinth. They also get sensorineural hearing loss. Normal labyrinthitis ossificans. Otosclerosis, fenstral and retrofenestrol. A better term would actually be otospongiosis, as the bone becomes more lytic, instead of sclerotic. When I say conductive hearing loss in an adult female, you say this. Fenstral, this is bony resorption anterior to the oval window at the fistula antifenestrone. If not addressed, the footplate will fuse to the oval window. Retrofenestrol, this is a more severe form, which has progressed to have demineralization around the cochlea. This form usually has a sensorineural component, and is bilateral and symmetric nearly 100% of the time. 206. Middle ear. Otitis media, OM, this is a common childhood disease with a fusion and infarction of the middle ear. It's more common in children and patients with Down syndrome because of a more horizontal configuration of the eustachian tube. It's defined as chronic if you have fluid persisting for more than 6 weeks. The complications are more of an issue, and more amenable to multiple choice questions. Complications of OM. Coalescent mastoiditis, erosion of the mastoid septae with or without intramastoid abscess. Facial nerve palsy, secondary to inflammation of the tympanic segment, more on this below. Dural sinus thrombosis, adjacent inflammation may cause thrombophlebitis or thrombosis of the sinus. This in itself can lead to complications. Venous infarct, this can occur secondary to dural sinus thrombosis. Otitic hydrocephalus, venous thrombosis can affect resorption of CSF and lead to hydrocephalus. Meningitis and labyrinthitis can both occur. 207. Cholesteatoma, this is a bunch of exfoliated skin debris growing in the wrong place. It creates a big inflammation ball which wrecks the temporal bone and the ossicles. The idea is basically this: you have two parts to the eardrum, a flimsy wimpy part, pars flaccida, and a tougher part, pars tensa. The flimsy flaccida is at the top and the tensa is at the bottom. If you acquire a hole with some inflammation, infection involving the pars flaccida, you can end up with this ball of epithelial crap growing and causing inflammation in the wrong place. Cholesteatoma, order of pars flaccida, cholesteatoma. Destruction predictable and testable. L. The SC, udum. 2. The ossi/ES, long process of the incus. 3. The lateral segment of. Typical the semicircular canal. Location with erosion of scutum, arrow, they restrict diffusion of dash. Pars flaccida type, pars tensa type. Acquired types are more common, typically the inner ear structures are involving the pars laxida. They grow into earlier and more often prusox space. This is less common than the flaccida. The scutum is eroded early, maybe first, type considered a very specific sign of acquired cholesteatoma. The malleus head is displaced medially. TLTE long process of the incus is the most common segment of the ossicular chain to be eroded. Fistula to the semicircular canal most commonly involves the lateral segment. Labyrinthine fistula, this is a potential complication of cholesteatoma, can also be congenital or iatrogenic, in which there is a bony defect between the inner ear and tympanic cavity. The lateral semicircular canal is most often involved. 208. 209. Superior semicircular canal dehiscence, this is an ant mini. It's supposedly from long-standing ICP, although the most likely way this will be asked is either 1. What is it? With a picture, or 2. Noise-induced vertigo, or Tullio's phenomenon. You are probably wondering who Tullio was. Pietro Tullio was some mad scientist who drilled holes in the semicircular canals of pigeons, then observed that they became off balance. When he exposed them to sound, he also created a pigeon rat, like Hugo Simpson did in the 1996 Simpsons Halloween special. This is not confirmed. Normal anatomy. External ear. Superior semicircular canal dehiscence. Necrotizing external otitis, this is a raging terrible infection of the external auditory canal. You are going to see swollen EAC soft tissues, probably with a bunch of small abscesses, and adjacent bony destruction. They always, 95%, have diabetes, and the causative agent is always, 98%. Pseudomonas. The facial nerve. There are only 2 or 3 things that are likely to be tested regarding the facial nerve. Which parts normally enhance? It's easier to remember what does not. The systemal, canalicular, and labyrinthine segments should not enhance. The remainder of the nerve, the intra temporal course, can enhance, tympanic, mastoid. Normal enhancement is due to the perineural venous plexus. 2. What causes abnormal enhancement? The big one is Bell's palsy. Lyme's, Ramsay-Hunt, and cancer can do it too. 3. When do you damage the facial nerve? Usually the transverse T-bone fracture, more than TB longitudinal. 210. Section 12. Skull base and sinuses. Paget's, this is discussed in great depth in the MSK chapter. Having said that, I want to remind you of the Paget skull changes. You can have osteolysis as a well-defined large radiolucent region favoring the frontal and occipital bones. Both the inner and outer table are involved. The buzzword is osteolysis circumscripta. Paget, hesitant face skull-related complications. Deafness is the most common complication. Cranial nerve paresis, basilar invagination, hydrocephalus, brainstem compression secondary, high-grade, osteosarcoma. Paget's osteolysis circumscripta, lytic phase, thickened expanded skull, sclerotic phase. Chodoma, midline, and clondrosarcoma, Ojave midline, discussed on page 58. Fibrous dysplasia, the ground glass lesion. If you are getting ready to call its Paget, stop and look at the age. Paget is typically an older person, 8% at 80, whereas fibrous dysplasia is usually in someone less than 30. Trivia, classically fibrous dysplasia of the skull spares the otic capsule McCune-Albright syndrome, multifocal fibrous dysplasia, café au lait spots, and precocious puberty. The outer table is favored, Paget's tends to favor in the inner table. 211. Sinuses. Juvenile nasal angiofibroma, JNA, often you can get this one right just from the history. Male teenager with nose bleeds, obstruction is actually a more common symptom. Anthracoanal polyp, also seen in young adults, 30s to 40s, this time with nasal congestion eye obstruction symptoms. This one arises within the maxillary sinuses, and passes through and enlarges the sinus ostium, or accessory ostium. Buzzword is widening of the maxillary ostium. Classically, there is no associated bony destruction, but instead smooth enlargement of the sinus. The polyp will extend into the nasopharynx. This thing is basically a monster inflammatory polyp with a thin stalk arising from the maxillary sinus. Inverted papilloma, this uncommon tumor has distinctive imaging features, which therefore make it testable. The classic location is the lateral wall of the nasal cavity, most frequently related to the middle turbinate. Impaired maxillary drainage is expected. A focal hyperostosis tends to occur at the tumor origin. The MRI buzzword is cerebriform pattern, which sorta looks like brain on TL and T2. Another high-yield pearl is that 10% harbor a squamous cell CA. Esthesia neuroblastoma, this is a neuroblastoma of olfactory cells, so it's gonna start at the cribriform plate. It classically has a dumbbell appearance with growth up into the skull and growth down into the sinuses, with a waist at the plate. There are often cysts in the mass. There is a bimodal age distribution. Things to know. Dumbbell shape with wasting at the cribriform plate is classic. Intracranial posterior cyst is a diagnostic. Look, octreotide scan will be positive, since it is of neural crest origin. Squamous cell ISNUC, squamous cell is the most common bead and neck cancer. The maxillary antrum is the most common location. It's highly cellular and therefore low on T2. Relative to other sinus masses it enhances less. SNUC, the undifferentiated squamor, is the monster steroid-up version of a regular squamous cell. They are massive and seen more in the ethmoids. Asterisk summary chart on sinus tumors in the strategy chapter. Epistaxis, this is usually idiopathic, although it can be iatrogenic, picking it too much or not enough. They could get sneaky and work this into a case of LLL it. The most common location is the anterior septa. Area, Kieselbach plexus, but because these are anterior they tend to be easy to compress manually. The posterior ones are less common, 5%, but tend to be the ones that bleed like stink, need angio. Most cases are given a trial of nasal packing. When that fails, the NIR team is activated. The main supply to the posterior nose is the sphenopalatine artery, terminal internal maxillary artery, and tends to be the first-line target. Watch out for the variant anastomosis between the ECA and ophthalmic artery, you don't want to embolize the eye. 212. LL section 13. MOF and jaw. Floor of mouth dermoid epidermoid. There isn't a lot of trivia about these other than the buzzword and what they classically look like. The buzzword is sac of marbles, fluid sac with globules of fat. They are typically midline. Ranula, this is a mucus retention cyst. They are typically lateral. There are two testable pieces of trivia to know. L, they arise from the sublingual gland eye space, and 2, use the word plunging once it's under the mylobuoid muscle. Torus palatinus, this is a normal variant that looks scary. Because it looks scary, some multiple choice writer may try and trick you into calling it cancer. It's just a bony exostoses that comes off the hard palate in the midline. Classic history, grandma's dentures won't stay in. Coelolithiasis, stones in the salivary ducts. The testable trivia includes 1. Most commonly in the submandibular gland duct Wharton's, 2. Can lead to an infected gland sialodinitis, and 3. Chronic obstruction can lead to gland fatty atrophy. Odontogenic infection, these can be dental or periodontal in origin. If I were writing a question about this topic, I would ask 3 things. The first would be that infection is more common from an extracted tooth than an abscess involving an intact tooth. The second would be that the attachment of the mylohyoid muscle to the mylohyoid ridge dictates the spread of infection to the sublingual and submandibular spaces. Above the mylohyoid line, anterior mandibular teeth, goes to the sublingual space, and below the mylohyoid line, second and third molars, goes to the submandibular space. The third thing I would ask would be that an odontogenic abscess is the most common masticator space, mass, in an adult. Sublingual space, above the mylohyoid line, anterior mandibular teeth. Submandibular space, below the mylohyoid line, second and third molars. 213. Ludwig's angina, this is a superaggressive cellulitis in the floor of the mouth. If they show it, there will be gas everywhere. Trivia, most cases start with an odontogenic infection. Osteonecrosis of the mandible, the trivia, is most likely gonna be etiology. Just remember it is related to prior radiation, licking a radium paintbrush, or bisphosphonate treatment. Cancer squamous cell is going to be the most common cancer of the mouth and head and neck. In an older person think drinker and smoker. In a younger person think HPV. HPV-related SECs tend to be present with large necrotic level 2A nodes, don't call it a brachia. Cleft cyst. Classic scenario equals young adult with new level 2 neck mass equals HPV-related SCC. Thyroglossal duct cyst, this can occur anywhere between the foramen cecum, the base of the tongue, and the thyroid gland. They are usually found in the midline at or above the hyoid. It looks like a thin-walled cyst. Further discussion in the endocrine chapter. Classic Moutley pictures. Ludwig's angina osteonecrosis. Of jaw. Ranula. 214. L. L. RL. L lesions of the jaw. There are a bunch of these and they all look pretty similar. Lesions in the jaw are broadly grouped into either odontogenic, from a tooth, or non-odontogenic, not from a tooth. The non-odontogenic stuff you see in the mandible is the same kind of stuff you see in other bones, ABCs, simple bone cysts, osteomyelitis, myeloma, plasmacytoma, etc. I think if a test writer is going to show a jaw lesion, they probably are going to go for odontogenic type. Obviously your answer choices will help you decide what they are going for. The other tip is that odontogenic lesions are usually associated with a tooth. I'm going to pick 5 that I think are most likely to be asked and focus on how I would tell them apart. Periapical cyst, radicular cyst, this is the most common type of odontogenic cyst. They are typically the result of inflammation from dental caries, less commonly trauma. The inflammatory process results in a cystic degeneration around adamantinoma of the jaw. This is another tumor, locally aggressive. The appearance is variable, but for the purpose of multiple choice, I would expect the most classic look, multicystic with solid components, and expansion of the mandible. Out of the 4 I've discussed, this will be the most aggressive looking one. If they show you a really aggressive looking lesion, especially if it has multiple soap bubbles, you should consider this. Key points: hallmark equals extensive tooth root absorption. Mandibular expansion. Solid component, shown on MR or CT, favors the DX of ameloblastoma. About 5% arise from dentigerous cysts. Odontoma, this is the easy one to pick out because it's most likely to be shown in its mature solid form. They start out lucent. It's actually the most common odontogenic tumor of the mandible. It's basically a tooth hamartoma. Key point J. Radiothense with a lucent rim, ____. 216. L. Section 14. Suprahyoid neck. The suprahyoid neck is usually taught by using a spaces method. This is actually the best way to learn it. What space is it? What is in that space? What pathology can occur as the result of what normal structures are there? Example, lymph nodes are there, thus you can get lymphoma or a met. Parotid space. The parotid space is basically the parotid gland and portions of the facial nerve. You can't see the facial nerve, but you can see the retromandibular vein, which runs just medial to the facial nerve. Another thing to know is that the parotid is the only salivary gland to have lymph nodes, so pathology involving the gland itself, and anything lymphatic related is fair game. Parotid space contains the parotid gland, cranial nerve 7, facial, retromandibular vein. 217. Pathology. Pleomorphic adenoma, benign mixed tumor. This is the most common major and minor salivary gland tumor. It occurs most commonly in the parotid, but can occur in the submandibular or sublingual glands. 90% of these tumors occur in the superficial lobe. They are commonly T2 bright, with a rim of low signal. They have a small malignant potential and are treated surgically. Superficial vs deep, involvement of the superficial, lateral to the facial nerve, or deep, medial to the facial nerve, lobe is critical to the surgical approach. A line is drawn connecting the lateral surface of the posterior belly of the digastric muscle and the lateral surface of the mandibular ascending ramus to separate superficial from deep. Apparently, if you resect these like a clown you can spill them, and they will have a massive ugly recurrence. Warthans, this is the second most common benign tumor. This one only occurs in the parotid gland. This one is usually cystic, in a male, bilateral, 15%, and in a smoker. As a point of total trivia, this tumor takes up pertechnetate. It's basically the only tumor in the parotid to do it, ignoring the ultra-rare parotid oncocytoma. Mucoepidermoid carcinoma, this is the most common malignant tumor of minor salivary glands. The general rule is, the smaller the gland the more common the malignant tumors, the bigger the gland the more common the benign tumors. There is a variable appearance based on the histologic grade. There is an association with radiation. Adenoid cystic carcinoma, this is another malignant salivary gland tumor, which favors minor glands but can be seen in the parotid. The number one thing to know is perineural spread. This tumor likes perineural spread. When I say adenoid cystic you say perineural spread. Pearl, I used to think that perineural tumor spread would widen a neural foramen ovale for example. RT still might, but it's been my experience that a nerve sheath tumor, schwannoma, is much more likely to do that. Let's just say for the purpose of multiple choice that neural foramina widening is a schwannoma, unless there is overwhelming evidence to the contrary. Lymphoma, because the parotid has lymph nodes, it's the only salivary gland that does. You can get lymphoma in the parotid, primary or secondary. If you see it and it's bilateral, you should think Sjogren's. Sjogren's patients have a big risk, like 1/00 of parotid lymphoma. Like lymphoma is elsewhere in the body, the appearance is variable. You might see bilateral homogeneous masses. For the purposes of the exam, just knowing you can get it in the parotid, primary or secondary, and the relationship with Sjogren's is probably all you need. 218. L. Other parotid trivia. Acute parotitis, obstruction of flow of secretions, is the most common cause. They will likely show you a stone or stones in Stenson's duct which will be dilated. The stones are calcium phosphate. Post-infectious parotitis is usually bacterial. Mumps would be the most common viral cause. As a point of trivia, coelography is contraindicated in the acute setting. Benign lymphoepithelial disease, you have bilateral mixed solid and cystic lesions with diffusely enlarged parotid glands. This is seen in IDV. The condition is painless, unlike parotitis, which can enlarge the glands. Sjogren's, autoimmune lymphocyte-induced destruction of the gland. Dry eyes and dry mouth. Typically seen in women in their 60s. Increased risk, like Lewis, risk of non-Hodgkin's malt-type lymphoma. There is a honeycombed appearance of the gland. 219. Carotid space. Carotid space contains carotid artery, jugular vein, portions of CN9, CN10, CN11. Internal jugular chain lymph nodes. There are 3 classic carotid space tumors, 1 paraganglioma, 2 schwannoma, 3 neurofibroma. Paragangliomas, there are 3 different ones worth knowing about based on location. The imaging features are the same. They are hypervascular, intense tumor blush, with a salt and pepper appearance on MRI from all the heterogeneous stuff and flow voids. They can be multiple and bilateral in familial conditions. M1N octreotide accumulates in these tumors, receptors for somatostatin. Carotid body tumor equals carotid bifurcation, splaying, CA and ECA. Glomus jugulare equals skull base, often with destruction off jugular foramen. Middle ear floor destroyed equals glomus jugulare. Level of carotid bifurcation G low muse VA gale equals above carotid bifurcation, but below the jugular foramen. Glomus tympanicum equals confined to the middle ear. Buzzword is overlying the cochlear promontory. Middle ear floor intact equals glomus tympanum. 220. L. Schwannoma can involve the 9, 10, 11, and even 121HCN. Schwannoma not all that vascular on angio no salt and pepper not 111 in octreotic avid no flow voids, target sign. Paraganglioma hypervascular, tumor blush on angio, salt and pepper look on MRI 1 LLFN octreotide avid flow voids. Lemierre syndrome, this is a thrombophlebitis of the jugular veins with distant metastatic sepsis, usually septic emboli in the lung. It's found in the setting of oropharyngeal infection, pharyngitis, tonsillitis, peritonsillar abscess, or recent ENT surgery. Lymph nodes equals metastatic lesions from squamous cell cancer frequently involve this area. Masticator space. As the name implies, this space contains the muscles of mastication, masticator, temporalis, medial and lateral pterygoids. Additionally, you have the angle and ramus of the mandible, plus the inferior alveolar nerve. A trick to be aware of is that the space extends superiorly along the side of the skull via the temporalis muscle. So aggressive neoplasm or infection may ride right up there. 221. Odontogenic infection. In an adult, this is the most common cause of a masticator space mass. If you see a mass here, the next move should be to look at the mandible on bone windows. Just in general, you should be on the lookout for spread via the pterygopalatin fossa to orbital apex and cavernous sinus. The relationship with the mylohyoid makes for good trivia, as discussed above. Sarcomas. In kids, you can run into nasty angry masses like rhabdomyosarcomas. You can also get sarcomas from the bone of the mandible. Chondrosarcoma favors the TMJ. Cavernous hemangiomas. These can also occur, and are given away by the presence of phleboliths. Venous or lymphatic malformations may involve multiple compartments eye spaces. Asterisk. Congenital stuff and aggressive infection/cancer tends to be transfacial. Perineural spread. You can have perineural spread from a head and neck primary along the 5-1-HCN. When I say perineural spread, you should think two things: 1. Adenoid cystic minor salivary tumor, and 2. Melanoma. Nerve sheath tumors. Since you have a nerve, you can have a schwannoma or neurofibroma OFV3. Remember, the schwannoma is more likely to cause the foramina expansion vs perineural tumor spread. 222. L. Retropharyngeal space. I. Danger space. Behind the middle layer of deep cervical fascia but anterior to the alar fascia, lives this midline space. Danger space, the so-called danger space, is actually just posterior to the true retropharyngeal space, behind the alar layer of fascia. It's a potential space that you can't see unless it's distended. Certain anatomists like to make the distinction that this space is separate from the true retropharyngeal space, others lump them together. If forced to choose, simply read the mind of the question writer to decide which camp he/she falls into. I would pick them as separate entities because people who do academics I write questions tend to enjoy making things overly complicated. So what's the danger and infection in the danger space? It tracks down into the mediastinum, so you can dump pus, or cancer, right into the mediastinum. That's bad. Infection, involvement of the retropharyngeal space, most often occurs from spread from the tonsillar tissue. You are going to have enhancing soft tissue and stranding in the space. You should evaluate for spread of infection into the mediastinum. Necrotic nodes, squamous cell mets or suppurative infection to the lateral retropharyngeal nodes of Riviere. Papillary thyroid cancer can also met here. Lymphoma can involve these nodes but won't be necrotic until treated. Retropharyngeal abscess, peritonsillar abscess, suppurative node of Riviere. 223. Neck infection syndromes. Grisel syndrome, torticollis with atlantoaxial joint inflammation seen in ILNN surgery or retropharyngeal abscess. Lemierre syndrome, URI, neck injection, or recent ENT surgery leads to jugular vein thrombosis and septic emboli. Buzzword bacteria equals Fusobacterium necroforum. A. Parapharyngia/space. The parapharyngeal space is primarily a ball of fat with a few branches of the trigeminal nerves and the pterygoid veins. The primary utility of the space is when it is displaced, discussed below. Mets and infections can directly spread into this space, squamous cell cancer from tonsils, tongue, and larynx. Cancer and infection can spread rapidly in a vertical direction through this fat. The parapharyngeal space is bordered on four sides by different spaces. If you have a mass dead in the middle, it can be challenging to tell where it's coming from. Using the displacement of fat, you can help problem solve. Much more important than that, this lends itself very well to multiple choice. Parotid mass pushes medially, PM. Masticator superficial mucosal space equals lateral displacement T. 224. L. RL section 15. Squamous cell CA. When you are talking about head and neck cancer, you are talking about squamous cell cancer. Now, this is a big complex topic and requires a fellowship to truly understand. I get good at. Obviously, the purpose of this book is to prepare you for multiple choice test questions, not teach you practical radiology. If you want to actually learn about head and neck cancer for a practical sense, you can try and find a copy of Hamsberger's legendary handbook, which has been out of print for 20 years, but who has time for that? Now for the trivia. Lymph node anatomy. Posterior border submandibular gland jugular fossa. Testable trivia. Anterior belly of Diggins-Trick separates IA from LB. Stylohyoid muscle, posterior submandibular gland, separates 1B from 2A. Spinal accessory nerve, jugular, separates 2A from 2B. Vertical borders, 2 to 3 equals lower hyoid, 3 to 4 equals lower cricoid. Floor of the mouth, SCC. I touched on this once already. Just remember smoker/drinker in an old person. HPV in a young person. Necrotic level 2 nodes can be a presentation, not a brachia. Cleft cyst. 225. Nasopharyngeal SCC. This is more common in Asians and has a bimodal distribution, group 1 15 to 30, typically Chinese, and group 2 40. Involvement of the parapharyngeal space results in worse prognosis compared to nasal cavity or oropharynx invasion. The most common location is the fossa of Rosenmuller for If you see 1. A unilateral mastoid effusion, or 2. A pathologic retropharyngeal node, look in the 4. The earliest sign of nasopharyngeal SCC is the effacement of the fat within the 4. If you see a supraclavicular node, then you should look closely at the bones for METs, especially the clivus. Unilateral mastoid effusion fossa of Rosenmuller mass PET avid. Laryngeal SCC. The role of the radiologist is not to make the primary cancer diagnosis here, but to assist in staging. Laryngeal cancers are subdivided into A. Supraglottic, B. Glottic, and C. Infraglottic types. Transglottic would refer to an aggressive cancer that crosses the laryngeal ventricle. Things to know about laryngeal SCC. Glottic SCC has the best outcome, least lymphatics, and is the most common, 60%. Subglottic is the least common, 5%, and can be clinically silent till you get nodes. Subglottic tumors are often small compared to nodal burden. Fixation of the cords indicates at least a T3 tumor. The only reliable sign of cricoid invasion is tumor on both sides of the cartilage. Irregular sclerotic cartilage can be normal. Invasion of the cricoid cartilage is a contraindication to all types of laryngeal conservation surgery. Cricoid cartilage is necessary for postoperative stability of the vocal cords. Paraglottic space involvement makes the tumor T3 and transglottic. This is best seen in coronals. 226. Section 16. Infrahyoid neck. Laryngocele. When the laryngeal saccule dilates with fluid or air, you call it a laryngocele. Why does it dilate? Usually because it's obstructed, and the testable point is that 15% of the time that obstruction is a tumor. Laryngocele. Vocal cord paralysis. The affected side will have an expanded ventricle. It's the opposite side with a cancer. If you see it on the left, a good next step question would be to look at the chest for recurrent laryngeal nerve involvement at the AP window. Buzzword equals hoarseness. If you see hoarseness in the question header, you need to think recurrent laryngeal nerve compression in the AP window, either from a mass/node or aortic path. Vocal cord paralysis, upsilateral expanded ventricle, AP window, PET avid node. 227. SECR10N11 orbit. Congenital. Coloboma. This is a focal discontinuity of the globe, failure of the choroid fissure to close. They are usually posterior. If you see a unilateral one, think sporadic. If you see bilateral ones, think charge, coloboma, heart, goo, ears. Persistent hyperplastic primary vitreous, PHPV. This is a failure of the embryonic ocular blood supply to regress. It can lead to retinal detachment. The classic look is a small eye, microphthalmia, with increased density of the vitreous. No calcification. Bilateral coloboma, charge syndrome. Retinal detachment in the setting of PHPV. Coates disease. The cause of this is a retinal telangiectasis that results in leaky blood and subretinal exudate. It can lead to retinal detachment. It's seen in young boys and typically unilateral. The key detail is that it is not calcified. Retinoblastoma is. Coates disease has a smaller globe. Retinoblastoma has a normal-sized globe. Retinal detachment. This can occur secondary to PHPV or Coates. It can also be caused by trauma, sickle cell, or just old age. The imaging finding is a V or Y-shaped appearance due to lifted up retinal leaves and subretinal fluid, as seen in the PHPV case above. Globe size, a source of possible trivia. Retinoblastoma, normal size toxocariasis, normal size PHPV, small size, normal Burle age, retinopathy of prematurity, bilateral small Coates, smaller size. 228. Orbital tumors. Optic nerve glioma. These almost always, 90%, occur under the age OF20. You see expansion eye enlargement of the entire nerve. If they are bilateral, you think about NF1. They are most often grade 1 pilocystic astrocytomas. If they are sporadic, they can be GBMs and absolutely destroy you. Optic nerve sheath meningioma. The buzzword is tram track calcifications. Another buzzword is donut appearance, with circumferential enhancement around the optic nerve. LGG4 orbit. Tram track equals meningioma. Orbital pseudotumor. This is one of those LGG4 idiopathic inflammatory conditions that involves the extraocular muscles. It looks like an expanded muscle. The things to remember are that this thing is painful. Unilateral, it most commonly involves the lateral rectos, and it does not spare the myotendinous insertions. Remember that Graves' docs not cause pain, and docs spare the myoctenous insertions. It gets better with steroids. It's classically T2 dark. Tolosa-Hunt syndrome. This is histologically the same thing as orbita J pseudotumor, but instead involves the cavernous sinus. It is painful, just like pseudotumor, and presents with multiple cranial nerve palsies. It responds to steroids use like P-scutotumor. Lymphocytic hypophysitis. This is the same deal as orbital P-scutotumor and Tolosa-Hunt, except it's the pituitary gland. Just think enlarged pituitary stalk in a postpartum third trimester woman. It looks like a pituitary adenoma. But it classically has a T2 dark NM. Pseudotumor Tolosa-Hunt lymphocytic hypophysitis involves ocular muscles, involves cavernous sinus, dark T2 signal around gland. 229. Dermoid. This is the most common benign congenital orbital mass. It's usually superior and lateral, arising from the frontozygomatic suture, and presenting in the first 10 years of life. It's gonna have fat in it, like any good dermoid. The location is classic. Orbital dermoid, classic location. Rhabdomyosarcoma, most common extraocular orbital malignancy in children. Dermoid is most common benign orbital mass in child. When they do occur, 40% of the time it's in the head and neck, and then most commonly it's in the orbit. It's still rare as hell. Metastatic neuroblastoma. This has a very classic appearance of raccoon eyes on physical exam. The classic location is periorbital tumor IR. Filtration with associated proptoses. Don't forget a basilar skull fracture can also cause raccoon eyes, so clinical correlation is advised. Metastatic breast cancer. This is classic gamesmanship here. The important point to know is that unlike primary orbital tumors that are going to cause proptoses, classically the breast cancer met causes a desmoplastic reaction and enophthalmos. Lymphoma. There is an association with chlamydia psittaci, the bird fever thing, and malt lymphoma of the orbit. It usually involves the upper outer orbit, closely associated with the lacrimal gland. It will enhance homogeneously and restricts diffusion, just like in the brain. Globe tumors. Melanoma. This is the most common intraocular lesion in an adult. If you see an enhancing soft tissue mass in the back of an adult's eye, this is the answer. Here are 4 ways you could ask a question about this. 1. Show a picture. What is it? 2. Ask what the most common intraocular lesion in an adult is. 3. Ask the buzzword collar button shaped, which is related to Brooks membrane. 4. Strong predilection for liver mets. Next step, liver MR. Retinoblastoma. This is the most common primary malignancy of the globe. The step I question is RB suppressor gene, chromosome 13. That's the same chromosome osteosarcoma patients have issues with, and why these guys are at increased risk of facial osteosarcoma after radiation. If you see calcification in the globe of a child, this is the answer. The globe should be normal in size, or bigger, where Coates is usually smaller. It's usually seen before age 3, rare after age 6. The trivia is gonna be where else it occurs. They can be bilateral, both eyes, 30%, trilateral, both eyes, and the pineal gland, and quadrilateral, both eyes, pineal, and suprasellar. 230. Orbital vascular malformations. Lymphangioma. These are actually a mix of venous and lymphatic malformations. They are ill-defined and lack a capsule. The usual distribution is infiltrative, multispatial, involving preseptal, postseptal, extraconal, and intraconal locations. Fluid levels are the money shot, and the most likely finding to be shown by someone writing a multiple-choice test question. They do not increase with Valsalva. Lymphangioma, fluid levels. Varix. These occur secondary to weakness in the postcapillary venous wall, gives you massive dilation of the valveless orbital veins. Most likely question is going to pertain to the fact that they distend with provocative maneuvers, Valsalva, hanging head, etc. Another piece of trivia is that they are the most common cause of spontaneous orbital hemorrhage. They can thrombose and present with pain. Carotid cavernous fistula. These come in 2 flavors, 1, direct, which is secondary to trauma, and 2, indirect, which just occurs randomly in postmenopausal women. The direct kind is a communication between the intracavernous ICA and cavernous sinus. The indirect kind is usually a dural shunt between meningeal branches of the ECA and cavernous sinus. Carotid, cavernous fistula, prominent left superior ophthalmic vein, prominent left cavernous sinus with proptoses. Orbital infection. Pulsatile cophthalmos the buzzword. LCC fistula is probably the most common cause. LNF1 can also cause it from sphenoid wing dysplasia. Preseptal/postseptal cellulitis. The location of orbital infections are described by their relationship to the orbital septum. The testable trivia is probably 1. That the orbital septum originates from the periosteum of the orbit and inserts in the palpebral tissue along the tarsal plate. 2. That preseptal infections usually start in adjacent structures likely teeth and the face, and that 3. Postseptal infections are usually from paranasal sinusitis. 231. Dacryocystitis. This is inflammation and dilation of the lacrimal sac. It has an ant-mini look, with a well-circumscribed round rim enhancing lesion centered in the lacrimal fossa. The etiology is typically obstruction then bacterial infection, staph and strep. Orbital subperiosteal abscess. If you get inflammation under the periosteum, it can progress to abscess formation. This is usually associated with ethmoid sinusitis. This also has a very classic look. Dacryocystitis, orbital subperiosteal abscess. Miscellaneous. Optic neuritis. There will be enhancement of the optic nerve, without enlargement of the nerve/sheath complex. Usually, 70% unilateral and painful. You will often see intracranial or spinal cord demyelination, in the setting of DeVeeks, neuromyelitis optica. 50% of patients with acute optic neuritis will develop MIS. Papilledema. This is really an eye exam thing. Having said that, you can sometimes see dilation of the optic nerve sheath. Thyroid orbitopathy. This is seen in 114 of the Graves cases, and is the most common cause of exophthalmos. The antibodies that activate TSH receptors also activate orbital fibroblasts and adipocytes. Things to know: risk of compressive optic neuropathy, enlargement of only muscle belly, Spares tendon, different than pseudotumor, not painful, different than pseudotumor, order of involvement, IR, MR, SR, LR, so I'm slow, thyroid orbit, Spares tendon insertion. 232. LL. Signon 1S spine. Anatomy trivia. Cord blood supply. There is an anterior blood supply and a posterior blood supply to the cord. These guys get taken out with different clinical syndromes. Anterior spinal artery arises bilaterally as 2 small branches at the level of the termination of the vertebral arteries. These 2 arteries join around the level of the foramen magnum. Artery of Adamkovich. This is the most notable reinforcer of the anterior spinal artery. In 75% of people, it comes off the left side of the aorta between T8 and TLL. It supplies the lower two-thirds of the cord. This thing can get covered with the placement of an endovascular stent graft for aneurysm or dissection repair leading to spine infarct. Posterior spinal artery arises from either the vertebral arteries or the posterior inferior cerebellar artery. Unlike the anterior spinal artery, this one is somewhat discontinuous and reinforced by multiple segmental or radiculopial branches. Conus medullaris, this is the terminal end of the spinal cord. It usually terminates at around L1. Below the inferior end plate of the L2I-L3 body should make you think tethered cord, especially if shown in a multiple choice setting. 233. Which nerve is compressed? There are 3 L pairs of spinal nerves, with each pair corresponding to the adjacent vertebra, the notable exception being the C8 nerve. Cervical disc herniations are less common than lumbar ones. The question is most likely to take place in the lumbar spine, the same spot most disc herniations occur. In fact, more than 90% of herniations occur at L4, L5, and LSSL. A tale of 2 herniations. It was the best of times. 2 was the worst of limes. Scenario / SCE11ARIO2. LS. L5, S1. LS L5, S1. A foraminal disc L5 will smash the exiting nerve. In this case, the LS nerve. A central or paracentral disc will smash the descending nerve. In this case, the S1 nerve. 234. L. Epidural fat. The epidural fat is not evenly distributed. The epidural space in the cervical cord is predominantly filled with venous plexus as opposed to fat. In the lumbar spine, there is fat both anterior and posterior to the cord. Epidural lipomatosis is a hypertrophy of this fat that only occurs with patients on steroids. On corticosteroids would be a huge clue. Degenerative changes. Stenosis. Spinal stenosis can be congenital, associated with short pedicles, or be acquired. The Tord-Pavlov ratio can be used to call it vertebral body width to cervical canal diameter, 0.85. Symptomatic stenosis is more common in the cervical spine versus the thoracic spine or lumbar spine. You can get some congenital stenosis in the lumbar spine from short pedicles, but it's generally not symptomatic until middle age. Disc nomenclature. In order to improve accuracy, with regard to the lumbar spine, various administrative regulatory bodies have decided on the vocabulary you are allowed to use. Focal herniation is a herniated disc less comprising than 90 degrees of the disc circumference. Broad-based herniation is a herniated disc in between 90 to 180 degrees. Protrusion is a term used when the distance between the edge of the disc herniation is less than the distance between the edges of the base. Extrusion is a term used when the edges of the disc are greater than the distance of the base. L _ dash _ eastroforaminal, broad-based, 90 foraminal par median central focal, 90. Schmorl node, this is a herniation of disc material through a defect in the vertebral body end plate into the actual marrow. Scheuermann's, this is multiple levels, at least 3, of Schmorl's nodes in the spine of a teenager, resulting in kyphotic deformity, 40 degrees in thoracic or 30 degrees in thoracolumbar. 235. Limb bus vertebra, this is a fracture mimic, that is the result of herniated disc material between the non-fused apophysis and adjacent vertebral body. End plate changes, commonly referred to as modic changes. There is a progression in the MRI signal characteristics that makes sense if you think about it. You start out with degenerative changes causing irritation, eye inflammation, so there is edema, T2 bright. This progresses to chronic inflammation which leads to some fatty change, just like in the bowel of an IBD patient, causing TL bright signal. Finally, the whole thing gets burned out and fibrotic, and it's TL and T2 dark. As a prominent factoid, type 1 changes look a lot like osteomyelitis, clinical correlation in recommended. Modic, end plate marrow changes associated with degenerative disease. Type 1 edema, ITL dark, T2 bright -- plus. I1I type 2, FTTL bright, T2 BI ___J, L __YP, scar _T1 dark, T2 dark ___. J. Annular tears, you can have tears in your dorsal annulus. They are usually bright on T2 and have a curvilinear look. They are so bright that some people call them high-intensity zones. They may be a source of pain, radial pain fibers trigger discogenic pain, but are also seen as incidentals. Myelogram technique. Big point, contrast should flow freely away from the needle tip, gradually filling the thecal sac. The outlining of the cauda equina is another promising sign that you did it right. If contrast pools at the needle tip or along the posterior or lateral thecal sac without free flow, a subdural injection or injection in the fat around the thecal sac should be suspected. Prior to the LP, per ACR/ASNR recommendations. Stop Coumadin 4 to 5 days, stop Plavix for 7 days, hold LMW heparin for 12 hours, hold heparin for 2 to 4 hours, document normal PIT, aspirin and NSAIDs are fine, not contraindicated. 236. L. Post-operative back trivia. Failed back surgery syndrome, another entity invented by NEJM to take down the surgical subspecialties. Per the NEJM, these greedy surgeons generally go from a non-indicated spine surgery to a non-indicated leg amputation to a non-indicated tonsillectomy on an innocent child. Textbooks will define it as recurrent or residual low back pain in the patient after disc surgery. This occurs about 40% of the time, probably more, since most back surgery is not indicated and done on inappropriate candidates. Causes of FBSS are grouped into early and late for the purpose of multiple choice test question writing. Complications of spine surgery: recurrent residual disc will lack enhancement, unlike a scar, which will enhance on delays. Epidural fibrosis scar, that is usually posterior, and enhance homogeneously. Arachnitis buzzwords: arc clump nerve roots, and empty theca/sac, enhancement for 6 weeks post-op is considered normal. After 6 weeks may be infectious or inflammatory. Conjoined nerve roots: 2 adjacent nerve roots sharing an enlarged common sleeve, at a point during their exit from the thecal sac. 12,000 square foot. As spine surgeons perform more and more unnecessary surgeries, they Mansion syndrome need something to spend all that money on. Please vs that, scar vs residual disc. TL pre-contrast: they will look the same, like a bunch of mushy crap. TL post-contrast: the disc will still look like mushy crap, but the scar will enhance. 237. Section 19. Seatbelts are for pussies. R.FFE degree -a-j z f.l _____________________ colon LL underscore LF underscore 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 dash dash a dash dash dash. Hangman bilateral pet. Pedicle or pars hyperextension underscore J. Acture of C2I teardrop and BJ Lexien or extension J flexion, more common, LJC1I, SHL, avulsion OJ spin pros, E ion dash 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 1. IJOT C7 or TL. I chance horizontal fractal, ETH oof I thoraco / umber SME. SME. L seatbelt. L dash dash thoraco / umber SME. L seatbelt. L dash dash a dash dash a dash a dash a dash 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 a dash a dash a J. Jefferson fracture. This is an axial loading injury, jumping into a shallow pool, with the blow typically to the top of the head. The anterior and posterior arches blow out laterally. They would most likely show it on a plain film open mouth odontoid view. The CT would be too easy. Remember, the CL lateral masses shouldn't slide off laterally. Important trivia to remember: neurologic cord damage is rare because all the force is directed into the bones. Odontoid fracture classification: type 1, upper part of odontoid, may be stable. This is actually rare. Type 2, fracture at the base, unstable, and by far the most common. Type 3, fracture through dens into the body of C2. This is unstable but has the best prognosis for healing. OS odontoideum, a mimic for a type 1 odontoid fracture. This is an ossicle located at the position of the normal odontoid tip, the orthotopic position. The base of the dens is usually hypoplastic. The thing to know are that this is prone to subluxatio and instability. Its association with Morquio syndrome. Orthotopic vs dystopic. Orthotopic is the position right on top of the dens. Dystopic is when it's fused to the clivus. Hangman's fracture, seen most commonly when the chin hits the dashboard in an MVA, direct blow to the face. The fracture is through the bilateral pars at C2, or the pedicles, which is less likely. You will have anterior subluxation of the C2 body. Cord damage is actually uncommon with these, as the acquired pars defect allows for canal widening. There is often an associated fracture of the anterior inferior comer at C2, from avulsion of the anterior longitudinal ligament. 238. L. Flexion teardrop. This represents a teardrop-shaped fracture fragment at the anterior inferior vertebral body. Flexion injury is bad because it is associated with anterior cord syndrome. 85% of patients have deficits. This is an unstable fracture, associated with posterior subluxation of the vertebral body. Anterior cord syndrome. The anterior portion of the cord is jacked. Motor function and anterior column sensations, pain and temperature are history. The dorsal column sensations, proprioception and vibration are still intact. Extension teardrop. Another anterior inferior teardrop-shaped fragment with avulsion of the anterior longitudinal ligament. This is less serious than the flexion type. Flexion teardrop impaction injury unstable. Extension teardrop distraction injury stable, maybe, hyperflexion hyperextension classic history, ran into wall classic eye listery, eye lit from behind. Flexion extension. Clay-Cheveller's fracture. This is an avulsion injury of a lower cervical eye upper thoracic spinous process, usually C7. It is the result of a forceful hyperflexion movement, like shoveling. The ghost sign describes a double spinous process at C6, C7. 239. Facet dislocation. This is a spectrum, sublux facets, perched, locked. Inverted hamburger sign, dash plus plus, normal. Unilateral. If you have unilateral facet, usually from hyperflexion and rotation, the superior facet slides over the inferior facet and gets locked. The unilateral is a stable injury. You will have the inverted hamburger sign on axial imaging on the dislocated side. Bun on bun. Bilateral. This is the result of severe hyperflexion. You are going to have disruption of the posterior ligament complex. When this is full on, you are going to have the dislocated vertebra displaced forward 1/2 the AP diameter of the vertebral body. This is highly unstable and strongly associated with cord injury. Atlantoaxial instability. The articulation between C1 and C2 allows for lateral movement. Shaking your head no. The transverse cruciform ligament straps the dens to the anterior arch of CL. The distance between the anterior arch and dens shouldn't be more than 5 millimeters. The thing to know is the association with Down syndrome and juvenile RA. Rotary subluxation can occur in children without a fracture, with the kid stuck in a cock-robin position, which looks like torticollis. Actually differentiating from torticollis is difficult and may require dynamic maneuvers on the scanner. This never, ever happens in the absence of a fracture in an adult who doesn't have Downs or RA. Having said that, people overcall this all the time in adults who have their heads turned in the scanner. Benign vs malignant compression fracture. This is a high-yield distinction and practical in the real world. Malignant benign convex posterior vertebral body cortex retropulsed fragment 1 involves posterior elements LT first TL and T2 dark band I epidural I parspinal mass multiple LE ons underscore. Trauma to the cord. There is a known correlation between spinal cord edema length and outcome. Having said that, you need to know the most important factor for outcome is the presence of a hemorrhagic spinal cord injury. These do very badly. 240. L. Central cord I. L. I anterior cord. I. Spinal cord syndromes. I old lady with spondylosis superior extremity deficit is. I or young person with bad. Section 20. Congenital spine. Pars interarticularis defects. This is considered a fatigue or stress fracture, probably developing in childhood. They are more common in athletic kids. They are usually not symptomatic, only 25% are. The most common level is L5S1, 90%, with all the rest at L4, L5. They tend to have more spondylolisthesis and associated degenerative change at L4, L5 than LSSI. They can be seen on the oblique plane film as a collar on the Scotty dog. Pars defects with anterolisthesis will have neuroforaminal stenosis, with spinal canal widening. When severe, will have spinal canal stenosis as well. Terminal ventricle, ventricularis terminalis. This is a developmental variant. Normally, a large portion of the distal cord involutes in a late stage of spinal cord embryology. Sometimes this process is not uniform, and you get stuck with a stupid-looking cyst at the end of your cord. These things are usually small, around 4 millimeters, and cause no symptoms. Sometimes they can get very big, like this example, and cause some neurologic symptoms. Terminal ventricle. 242. L. Spinal dysraphism. You can group these as open or closed, closed with and without a mass. Open means neural tissue exposed through a defect in bone and skin, spina bifida aprida. Closed means the defect is covered by skin, spina bifida occulta. Open spinal dysraphisms. This is the result of a failure of the closure of the primary neural tube, with obvious exposure of the neural placode through a midline defect of the skin. You have a dorsal defect in the posterior elements. The cord is going to be tethered. There is an association with diastematomyelia and CRE2 malformations. Early surgery is the treatment standard of care. Myelocele. This is the more rare type where the neural placode is flush with the skin. Myelomeningocele. This is the more common type, 98%, where the neural placode protrudes above the skin. These are more common with CRE2 malformations. Closed spinal dysraphisms with subcutaneous mass. Meningocele. This is herniation of a CSF-filled sac through a defect in the posterior elements, spina bifida. It is most typical in the lumbar or sacral regions, although they can occur in the cervical spine. They may be anterior, usually presacral. An important point is that neural tissue is not present in the sac. Lipomyelocele lipomyelomeningocele. These are lipoRNAs with a dural defect. On exam, you are going to have a subcutaneous fatty mass above the gluteal crease. These are 100% associated with tethered cord. Myelomeningocele may or may not. Terminal myelocystocele. This is a herniation of the terminal syrinx into a posterior meningocele via a posterior spinal defect. 243. Closed spinal dysraphisms without subcutaneous mass. Ultradural lipomas, most common in the thoracic spine along the dorsal aspect. They don't need to be, but can be, associated with posterior element defects. Fibrolipoma of the phylum terminate. This is often an incidental finding. There will be a linear TL bright structure in the filern terminale. The phylum is not going to be unusually thickened and the conus will be normally located. Tight phylum terminate. This is a thickened phylum terminale, 2 mm, with a low-lying conus below the inferior end plate of L2. You may have an associated terminal lipoma. The tethered cord syndrome is based on the clinical findings of low back pain and leg pain plus urinary bladder dysfunction. This is the result of stretching the cord with growth of the canal. Dermal sinus. This is an epithelium-lined tract that extends from the skin to deep soft tissues, sometimes the spinal canal, sometimes a dermoid or lipoma. These are TL low signal, relative to the background high signal from fat. Diastematomyelia. This describes a sagittal split in the spinal cord. They almost always occur between T9, SL, with normal cord both above and below the split. You can have 2 thecal sacs, or just one, and each hemichord has its own central canal and dorsal/ventral horns. Classification systems are based on the presence/absence of an osseous or fibrous spur, and duplication or non-duplication of the thecal sac. Kerr-Reno triad. Anterior sacral meningocele. Anorectal ma/ormation. Caudal regression. This is a spectrum of defects in the caudal region that ranges from partial agenesis of the coccyx to lumbosacral agenesis. The associations to know are Vactral and Kerr-Reno triad. Think about this with maternal diabetes. Blunted sharp high terminating cord is classic, with a shield sign, from the opposed iliac bones, no sacrum. Sacrococcygeal osseous defect, isometer sacrum. Fuckery. Note that the meningocele of Kerr-Reno is anterior. It's not posterior. A potential deployment of fuckery is to put posterior, sacral meningocele, as a distractor for Kerr-Reno triad. Anyone who would do that is an asshole, which happens to be posterior. 244. L. SEC110N21, spine miscellaneous. Vascular. AVFs IAVMs, there are 4 types. Type 1 is by far the most common, 85%. It is a dural AVF, the result of a fistula between the dorsal radiculomedullary arteries and radiculomedullary vein I-coronal sinus, with the dural nerve sleeve. It is acquired and seen in older patients who present with progressive radiculomyelopathy. The most common location is the thoracic spine. If anyone asks, the gold standard for diagnosis is angiography, although CTA or MRA will get the job done. You will have T2 high signal in the central cord, which will be swollen, with serpentine paramedullary flow voids, which are usually dorsal. Type II. Spinal AVM IAVFs. AVFs. Most common type, 85%. 245. Miscellaneous disorders affecting the spine. Paget's, this is discussed in detail in the MSK chapter, but is such a high-yield topic that it's worth touching on again. The incidence increases with age, around 8% at age 80. It's at increased risk for fracture, and has AL% risk of sarcoma degeneration, usually high grade. It's shown two ways in the spine: 1, an enlarged ivory vertebrae, 2, picture frame vertebrae, sclerotic border. Ivory vertebrae Paget's, or Mets. Renal osteodystrophy, another high-yield topic covered in depth in the MSK chapter. The way it's shown in the spine is the rugger jersey spine, with sclerotic bands at the top and bottom of the vertebral body. You could also have parspinous soft tissue calcifications. This vs that, rugger jersey vs Paget picture frame. Rugger jersey equals top and bottom only. Paget picture frame equals all for margins of the vertebral body. Osteopetrosis, another high-yield topic covered in depth in the MSK chapter. This is a genetic disease with impaired osteoclastic resorption. You have thick cortical bone, with diminished marrow. On plain film or CT, it can look like a rugger jersey spine or sandwich vertebra. On MR, you are going to have loss of the normal TL bright marrow signal, so it will be TL and T2 dark. H-shaped vertebra, this is usually a buzzword for sickle cell, although it's only seen in about 10% of cases. It results from microvascular end plate infarct. If you see H-shaped vertebra, the answer is sickle cell. If sickle cell isn't a choice, the answer is Gaucher's. Another tricky way to ask this is to say which of the following causes widening of the disc space. Widened disc space is another way of describing a H-shape without saying that. 246. L. Infectious. Discitis I osteomyelitis. Infection of the disc and infection of the vertebral body nearly always go together. The reason has to do with the route of seeding, which typically involves seeding of the vertebral end plate, which is vascular, subsequent eruption and crossing into the disc space, and eventual involvement of the adjacent vertebral body. Infection seeds vascular end plate, infection breaks into disc, infection crosses to other end plate. In adults, the source is usually from a recent surgery, procedure, or systemic infection. In children, it's usually from hematogenous spread. For the step 1 trivia, staph A is the most common bug, and always think about it for drug user. Almost always 80% of the time the ESR and CRP are elevated. Imaging, early on it's very hard to see with plain films, you will need MRI. You are looking for parspinal and epidural inflammation, T2 bright disc signal, disc enhancement. Vertebral osteomyelitis. 247. Pott's disease, TB of the spine, is more common in developing countries. It behaves in a few different ways, and that makes it easy to test on. Things to know about TB in the spine: it tends to spare the disc space, it tends to have multilevel thoracic, skip involvement, buzzword, calcified psoas abscess, buzzword, gibbous deformity, which is a destructive focal kyphosis. Brucellosis, this is uncommon in the USA. Its somewhat unique feature make it testable. Just know that it favors the lower lumbar spine and SI joints, and can spare the disc space similar to TB. Vertebral destruction and paraspinal abscess are actually less common. Step 1 buzzword was cow's milk or farm exposure. Epidural abscess, this is an infected collection between the dura and periosteum. It's usually MRSA, and the patient usually has IDV, or is a bad diabetic. This is most likely to be shown with diffusion. A collection that restricts is going to be an abscess in the spine and in the brain most of the time. It should also be TL dark, T2 bright, with peripheral enhancement. 248. L. Section 22 cord pathology. Syrinx, also known as a hole in the cord. People use the word syrinx for all those fancy French Latin words: hydromyelia, syringomyelia, hydrosyringomyelia, syringohydromyelia, syringobulbia, etc. They do this because they don't know what those words mean. Here is the way I do it: if there is a perfectly central high signal dilation in the middle of the cord, surrounded by totally normal cord, I call it central cord dilation, or benign central cord dilation. If there is the same thing but the cord around it looks sick, it's also got high signal, or the cord is atrophic, etc., then one use the word myelia. Myelia is a word to use when you want to say it's pathologic. Most, 90%, cord dilations, healthy and sick ones, are congenital, and associated with Chiari 1 and 11, as well as Dandy-Walker, Klippelfehl, and myelomeningocele. The other 10% are acquired either by trauma, tumor, or vascular insufficiency. Demyelinating. Broadly, you can think of cord pathology in 5 categories: demyelinating, tumor, vascular, inflammatory, and infectious. JN the real world, the answer is almost always MS, which is by far the most common cause. The other 3 things it could be are neuromyelitis optica, NMO, acute disseminating encephalomyelitis, ADEM, or transverse myelitis, trademark. Dash. Dash a dash a dash comma underscore dash a dash dash R. Dash dash. Dash. I see and enhance IMS usually short usually MS in the cord, multiple lesions over space and time. The lesions in the spine are typically short segment, 2, usually only affect half a part of the cord. The cervical cord is the most common location. There are usually lesions in the brain. If you have lesions in the cord, isolated cord lesions occur about 10% of the time. The lesions can enhance when acute, but this is more common than in the brain. You can sometimes see cord atrophy if the lesion burden is large. Transverse myelitis, this is a focal inflammation of the cord. The causes are numerous: infectious, post-vaccination, classic rabies, SLE, Sjogren's, paraneoplastic, AV malformations. You typically have at least 2/3 of the cross-sectional area of the cord involved, and focal enlargement of the cord. Splitters will use the terms acute partial for lesions less than 2 segments, and acute complete for lesions more than 2 segments. The factoid to know is that the acute partials are higher risk for developing MIS. ADEM, as described in the brain section, this is usually seen after a viral illness or infection, typically in a child or young adult. The lesions favor the dorsal white matter but can involve gray matter. As a pearl, the presence of cranial nerve enhancement is suggestive of ADEM. The step by trivia is that the anti-mu LGG test is positive in 50% of cases. Just like MS, there are usually brain lesions, although ADEM lesions can occur in the basal ganglia, and pons, which is unusual in MS. NMO, neuromyelitis optica, this is also sometimes called DeVeeks. It can be monophasic or relapsing, and favors the optic nerves and cervical cord. Tends to be longer segment than MS, and involve the full transverse diameter of the cord. Brain lesions can occur, more commonly in Asians, and are usually periventricular. If any PhDs ask, the reason the periventricular location occurs is that the antibody, NMO-IgG, attacks the aquaporin 4 channels, which are found in highest concentration around the ventricles. Subacute combined degeneration, this is a fancy way of describing the effects of a vitamin B12 deficiency. The classic look is bilateral symmetrically increased T2 signal in the dorsal columns, without enhancement. The appearance has been described as an inverted V sign. The signal change typically begins in the upper thoracic region, with ascending or descending progression. Underscore. MS. Trademark NMO MS Leishemia. Spinal cord infarct/ischemia can have a variety of causes. The most common cause is idiopathic, although I'd expect the most common multiple choice scenario to revolve around treating an aneurysm with a stent graft or embolizing a bronchial artery. Impairment involving the anterior spinal artery distribution is most common. With anterior spinal artery involvement, you are going to have central cord I anterior horn cell high signal on T2, because gray matter is more vulnerable to ischemia. The owl eye appearance of anterior spinal cord infarct is a buzzword. It's usually a long segment, being more than 2 segments. Diffusion using single-shot fast spin echo or line scan can be used with high sensitivity to compensate for artifacts from spinal fluid movement. 251. Inflammatory eye infectious. Arachnoiditis, this is a general term for inflammation of the subarachnoid space. It can be infectious but can also be post-surgical. It actually occurs about 10 to 15% of the time after spine surgery, and can be a source of persistent pain. I failed back. It's shown 2 ways. 1. Empty thecal sac sign, nerve roots are adherent peripherally, giving the appearance of an empty sac. 2. Central nerve root clumping. This can range in severity from a few nerves clumping together, to all of them fused into a single central scarred band. Empty tiltecal sac sign. Guillain-Barré syndrome, GBS, one of those weird autoimmune disorders that causes ascending flaccid paralysis. The step 1 trivia was Campylobacter, but you can also see it after surgery, or in patients with lymphoma or SLE. The thing to know is enhancement of the nerve roots of the cauda equina. Other pieces of trivia that are less likely to be asked are that the facial nerve is the most common cranial nerve affected, and that the anterior spinal roots enhance more than the posterior ones. Chronic inflammatory demyelinating polyneuropathy, CIDP, the chronic counterpart to GBS. Clinically, this has a gradual and protracted weakness. GBS improves in 8 weeks, CIDP does not. The buzzword is thickened, enhancing, onion bulb nerve roots. CIDP, diffuse thickening of the nerve roots. 252. L. 1__. Tumor, the classic The classic teaching is to first describe the location of the tumor as either 1. Intramedullary, 2. Extramedullary intradural, or 3. Extradural. This is often easier said than done. Differentials are based on the location. Ultramedullary. Ultramedullary, extramedullary, ultradural, extra.T-dural. Extramedullary, ultradural, extradural. Astrocytoma, ependymoma, hemangioblastoma, schwannoma, meningioma. Neurofibroma. Drop Mets disc disease, most common, bone tumors, Mets, lymphoma. 253. 1__. Tumor, the classic teaching is to first describe the location of the tumor as either 1. Intramedullary. Intramedullary, 2. Extramedullary intradural, or 3. Extradural. This is often easy. Ultramedullary. Ultramedullary, extramedullary, ultradural, extra.T-dural. Extramedullary. Extradural. Astrocytoma, ependymoma, hemangioblastoma, schwannoma, meningioma. Neurofibroma. Drop Mets disc disease, most common, bone tumors, Mets, lymphoma. 253. Intramedullary. Astrocytoma, this is the most common intramedullary tumor in PEDS. It favors the upper thoracic spine. There will be fusiform dilation of the cord over multiple segments. They are dark on TL, bright on T2, and they enhance. They may be associated with rostral or caudal cysts, which are usually benign syrinx formation. Astrocytoma most common in child. Epidymoma most common in adult. Eccentric heterogeneous enhancement. Central homogeneous enhancement. Ependymoma, this is the most common primary cord tumor of the lower spinal cord, conus I phylum terminale. This is the most common intramedullary mass in adults. Although you can certainly see them in the cervical cord as well. The myxopapillary form is exclusively found in the conus/phylum locations. They can be hemorrhagic and have a dark cap on T2. They have tumoral cysts about Y4 of the time. They are a typically long segment, averaging 4 segments. Myxopapillary equals most commonly located in the lumbar spine, conus/phylum location. Hemangioblastoma, these are associated with von Hipp. Lindau, 30%. The thoracic level is favored, second most common is cervical. The classic look is a wide cord with considerable edema. Adjacent serpinginous draining meningeal varicosities can be seen. Intramedullary Mets, this is very rare, but when it does happen it's usually lung, 70%. More often hemorrhagic. VHL associations. Pheochromocytoma, ACNS hemangioblastoma, cerebellum 75%, spine 25%, endolymphatic sac tumor, pancreatic cysts, pancreatic islet cell tumors, clear cell RCC. 254. L. Extramedullary intradural. Schwannoma, this is the most common tumor to occur in the extramedullary intradural location. They are benign, usually solitary, usually arising from the dorsal nerve roots. This can be mutable in the setting of NF2 and the Carney complex. The appearance is variable, but the classic look is a dumbbell with the skinny handle being the intraforaminal component. They are TL dark, T2 bright, and will enhance. They look a lot like neurofibromas. If they have central necrosis or hemorrhage that favors a schwannoma. Neurofibroma, this is another benign nerve tumor, composed of all parts of the nerve and sheath, that is also usually solitary. There are two flavors, solitary and plexiform. The plexiform is a multilevel bulky nerve enlargement that is pathognomonic for NF1. Their lifetime risk for malignant degeneration is around 5 to 10%. Think about malignant degeneration in the setting of rapid growth. They look a lot like schwannomas. If they have a hyperintense T2 rim with a central area of low signal, target sign, that makes you favor neurofibroma. Schwannoma. Do not envelop the adjacent nerve root solitary. Multiple makes you think NF2I. Cystic change I hemorrhage. Hemorrhage. Neurofibroma. Do envelop the adjacent nerve root, usually a dorsal sensory root. Solitary. Associated with NF-1, even when single. T2 bright rim. T2 dark center target sign. Meningioma. These guys adhere to but do not originate from the dura. They are more common in women, 70%. They favor the posterior lateral thoracic spine and the anterior cervical spine. They enhance brightly and homogeneously. They are often TL ISO to hypo and slightly T2 bright. They can have calcifications. Drop Mets, medulloblastoma, is the most common primary tumor to drop. Breast cancer is the most common systemic tumor to drop, followed by lung and melanoma. The cancer may coat the cord or nerve root, leading to a fine layer of enhancement. 255. Extradural. Vertebral hemangioma. These are very common, seen in about 10% of the population. They classically have thickened trabeculae appearing as parallel linear densities, jail bar or corduroy appearance. In the vertebral body they are Ti and T2 bright, although the extraosseous components typically lack fat and are iso-intense on TL. Osteoid osteoma. This is also covered in the MSK chapter, but as a brief review focusing on the spine they love to involve the posterior elements, 75%, and are rare after age 30. They tend to have a nidus and surrounding sclerosis. The nidus is T2 bright and will enhance. The classic story is night pain, better with aspirin. Radiofrequency ablation can treat them, under certain conditions. Osteoblastoma. This is similar to an osteoid osteoma, but larger than L.5 centimeters. Again, very often in the posterior elements, usually of the cervical spine. Aneurysmal bone cyst. These guys are also covered in the MSK chapter. They also like the posterior elements, and are usually seen in the first 2 decades of life. They are expansile, as the name implies, and can have multiple fluid levels on T2. They can get big and look aggressive. Giant cell tumor. These guys are also covered in the MSK chapter. These are common in the sacrum, although rare anywhere else in the spine. You don't see them in young kids. If they show this, it's going to be a lytic expansile lesion in the sacrum with no rim of sclerosis. Vertebra plana, the pancake flat vertebral body. Just say eosinophilic granuloma in a kid, could be neuroblastoma met, and metsi-myeloma in an adult. Chodoma. This is most common in the sacrum. They will want you to say clivus, that is actually number 2. The thing to know is that a vertebral primary tends to be more aggressive I malignant than their counterparts in the clivus and sacrum. The classic story in the vertebral column is involvement of 2 or more adjacent vertebral bodies with the intervening disc. Most are very T2 bright. Leukemia. They love to show it in the spine. You have loss of the normal fatty marrow, so it's going to be homogeneously dark on TL. More on this in the MSK chapter. Mets. The classic offenders are prostate, breast, lung, lymphoma, and myeloma. Think multiple lesions with low TL signal. Cortical breakthrough or adjacent paravertebral components are also helpful. 256. Blank for notes I scribbles. 257. Blank for notes I scribbles. 258. Chapter 13 Nuclear Medicine. Prometheus Yuan Harl, MD. Highest yield tip. Nuclear medicine is probably